Check. Testing one. Check. Check. Check one. ఎందుకు రాదు?
So, on behalf of Spine Society of Andhra Pradesh, it's my privilege to welcome you all to the 8th annual conference of Spine Society of Andhra Pradesh. Over the past 8 years, our society has grown and it has turning into a strong academic body. And our meetings are known for one-to-one interactions and very strong case-based discussions under the guidance of Dr. Rajshekharan sir. We are especially fortunate to have had sir, his support for the past 8 years. It's his vision and his affection towards SSAP have guided us to reach to this stage. And it's also our honor that we welcome Professor S.K. Srivastava sir, President of Association of Spine Surgeons of India, who will be participating in our discussion, also delivering the third SSAP Professor S. Rajshekharan oration. I warmly welcome all our consultants, my friends, and then postgraduate students. So without much delay, we'll start the program with small prayer, and we'll hand it over to Rajshekharan sir for the next proceedings. Prayer, sir. Yeah.
वक्रतुंड महाकाय कोटि सूर्य समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Thank you very much. So, sir, please take. So this sir is going to keep this session on avoiding complications in spine surgery. The format and everything sir will explain. So I'll request all the postgraduates to sit on the other side and the consultants to be here. So it is the best chance to engage ourselves and get maximum out of our esteemed faculty. There is no time restriction. There is no structured format like a lecture. Any time, if you have any doubts, you can just rise up and ask, and sir will take care of this. You can connect the laptop of sir. Yeah, done. Thank you.
Interested in the care of the patients. I mean, you have the name of person you can easily name. So it's an issue. So really very happy to have you here. Thank you very much for this. So you know this, if you are planning to be a spine surgeon, as you grow older, the degenerative conditions will increase. And patients are also nowadays demanding surgery. I can see a huge difference in the last 20 years. If you suggest a surgery, mostly they will say no. But now there are a lot of people who come to you and say, sir, I want this pain, I want to be normal, I want a surgery to get it. So industry is another big thing. They will push for more interventions, newer technologies, newer techniques. Whether it's useful or for the patient or not, surgeons will get fascinated by it and then I will get all. But another big problem is, if you consider all specialties of orthopedics, spine surgery has got a high reoperation and dissatisfaction rate. Now I have been operating trauma recently, sometimes I operate joint also, doing spine. But one aspect of it is, if the patient has got a severe back pain and sciatica and acute pain, he is more grateful to you than any other specialty. But unfortunately, there is a little bit of dissatisfaction rates and higher complication rates in spine surgery. And as you know, if that happens, it's a sad scenario. Then you don't know whether the patient is more unhappy or the surgeon is more unhappy. So we have to somehow prevent complication. So one complication prevention is almost equal to 10 or 15 high success stories, because one complication drains so much of time, effort, and resource from you when it's coming from spine surgery. And I always tell that surgical failures are multiple. I mean, because it's not just one person who is sad, but it's the doctor also. We also get as much affected with the failure rate, and patients and also the families. So we will try to look at how to think about when we need to have complication and what should happen and go through your. So this is a 18-year-old person, young man, just getting into college, and you can see that it's a very long time ago. He has a long history of back pain, on and off, and recently had some sports activities after which he has got an increased back pain. So he was not treated by us, but this is, so I don't have this view of X-rays. But as you can see here, this is a two-level problem, isn't it? So you can see that at L45 and also at L34 as well, that is correct. And not exactly sure of what was his presenting symptoms before. When you have a problem like this, the first thought that comes to your mind is, should I operate both, or should I not operate? Should I operate or not? If I operate, should I operate both? Let's say that he had a left-sided side, and he has a two-level issue. So what will be your thought from? He was with
First, take a good clinical history and radiculopathy, and examine the patient, sir, for power, motor, sensory, and.
All that is fundamental. So you will do a thorough clinical examination, because you will never operate on the MRI. Because
Yes.
we frequently have people who have big discs. In one of the courses here before, we just showed that the size of the disc, the location of the disc, and the length of the time the patient has the disc doesn't have any correlation to symptoms or the capacity to become better and calculated. So what we aim here is what is called what do we aim at? Clinical
Radiological diagnosis.
correlation
Yes, sir.
plus failure of calculation. So these four things come down. So the patient must have a perfect clinical symptoms that suggest you of some diagnosis. And that, and the X-rays and radiology, you find some problem. But then you match both and correlate. So you can have a patient who has got a large left-sided disc, but a patient who has got right-sided
symptoms. Yes.
Although 5% of you can have that, but still there is a discorrelation. Or there is a lot of instability but no back. So all these are called clinical radios with the absence of correlation. So you should have correlation. So definitely you will really get example. But he has gone through many episodes, and let's say he just has come to you in desperation. So when you have two level this, how will you manage? And you have two level this, but he has got a the second side.
Operative.
His mother wants to know both sides. This should be operated or only one or anybody. Then I would say anybody I mean like whatever you want to discuss with him. Yeah. So you know, fortunately in mind surgery there is something like for us. There is a root block. And it helps you to diagnose. It helps you for therapeutic trial. It also helps you to get time. And then with twice time, sometimes when you're not very sure of something, you should get a root block. So if you have here, you see that like L3-4, the left side is not so much. Although in the sagittal it is quite big. And you have only a large disc which is pressing on the nerve on the left side. So the most ideal thing would be to learn to give it. So you should give an L4-5. And then if it is 100% cure off, then would you need to then do the L3-4 test? No. So it really helps you to actually, number one, confirm that this guy has got sciatica nervosus problem. Then it also helps you to confirm that at 2 level, this surgery is not necessary. And believe me, as you go higher, L3-4, L2-3 hysterectomies are not good surgeries in young people. So they have serious problems when they start doing higher level, this surgeries in these people. And 2 level hysterectomy is not at all a good proposition for a young patient. You can have good results, but you can have awful bad results also after surgery. So you should never operate on the patient with it first. Yeah? So these are, you also must check.
Yeah, actually in this I am putting another set of patient. Similar looking MRI. Patient has severe back pain. He has lifted something in gym and he has severe back pain, but no radicular symptom. Now what will be the approach? And same MRI. Can you, Dr. Rajsekharan, can you go back to sagittal? Yeah, like this. Similar thing. Now many times these young patients, they have small snort. Okay, they have a small notching of the vertebral end plate, and this may be a discogenic pain, no radicular symptom. Apart from giving rest to the part and exercises, you should also investigate these patients for vitamin D deficiency. All these younger generation, they have their vitamin D10, like that, okay? And many a time these back pain may be because of the other thing also, and you should take care of that. Just I wanted to add.
So one more point younger spine surgeon in the offing. Whenever you have a patient like this, where it's not very, very clear that you have 2 or 3 different thought processes coming into your mind, many other patients, then you should never admit them at operation. This is one of the golden advices that I give you by a popular spine surgeon, that you should never admit So the patient has come to you for surgery from some other place. And so we are very happy that you did say surgery. So mother and father are very happy. They already love you a lot. Okay? So why are physiotherapists more popular than surgeons now? So first thing they tell when you go to them is they say, sir, surgery is not coming. And if you do it no, surgery, then the patient immediately get a good thing. So the family likes you a lot. So now he gets better. And he is okay. Then the family is yours or let's say you take no surgery, I went to the sound of your own, he just gave a manic injection and then it became completely out. And for water they want. So pain, headache, constipation also they come and see you and tell that the doctor is telling something and you take it off. So you give him the family off. Second scenario, he doesn't get better. After 1 week they come. There are more families that you require surgery. And then what do you do? They say, I find all these drugs and then it happens, okay, what to do? Then you do this. But you say, you need surgery. And the patient goes home and then he thinks, okay, let me wait for 1 week and he becomes better. That is the worst. It happens 50% of the time to people who tell every patient who they say, you need surgery, 50% of the patients get better. These days will go all around the place and tell, don't even go to Dr. Ashwin, he is a terrible guy. As soon as he said, operate, and see, I want to. Or he said, I went to this physiotherapist, he became tense and I became better. So this is exactly the reason why physiotherapists are becoming more popular. Surgeons are telling surgery immediately. And they are always telling no surgery. But this is a very important practical point for you to do. This patient had surgery. So you can see from this picture that there is a drain tube. So it's not a microsurgery or something like that. Open surgery he had. And on the second post-op day, he had very severe unbearable pain. What do you think of? Second post-op.
Sir, actually the hematoma which is formed over the cord that might be compressing, which leads to give severe radiculopathy, or the drain tube itself, it is irritable. Yes, sir. And the groin pain or
One of the things is if on the same day or the next day the patient complains of similar pain, this is a double level risk. But you have to be first of all worried about wrong level. Something wrong has happened. You wanted something to happen and it didn't happen. So wrong level surgery is something very common if you have to think of a single level surgery. Even here there is no doubt you could have operated on 2 levels. But here you can see some small laminectomy notching they have done, so you know they are at the right level. So one more thing you will have to think of, hematoma. So what will you do?
So again we'll wait, sir, not to get in a hurry. I'm telling patient that we need revision or something. We'll wait just and we'll give painkillers, and we can use some decadron or steroid so that it will provide some less inflammation over the cord and the root.
So you will reassure, give some painkillers, ask him to take rest and other things. So I mean this is a big problem, but in single level disc, same thing, you will have to first think of wrong level surgery, microdiscectomy or doing wrong side surgery, or you have to think back on whether you operated on the right patient. Is it the right diagnosis? This is very common. You have to go back and see on your MRI. For that you should know how to read your own MRI. This is very, very fundamental. If you are a spine surgeon, you should know how to read a spine MRI very thoroughly, because many surgeons don't know to read a spine MRI. But as I was telling this morning, some of the radiologists also don't give a perfect report on spine MRI. So if you rely on their report and you operate, you are in danger. So what to do is the big problem. So what they did was, if there is a very severe pain, one of the things that you can do is to do an MRI. In the acute period, MRI is useful to know at least that you operated on the same level. But some huge disc has come again, you can know, or some other problem is there. But in the first and second day, mostly it is useful for only same level, whether you have operated correctly, and also large hematomas. Sometimes you have big CSF leaks or something, seromas, everything you can understand. So MRI was not done, but on the third day, they gave an epidural injection. He said they gave an injection, but I had 50% relief, and discharged, and then asked to take rest for some time. So what is wrong here? So epidural in the immediate post-operative period is not a very good idea, isn't it? I mean, it doesn't serve much purpose, because epidural is given to reduce perineural inflammation, but this is not a inflammation, it is some either a compression or hematoma or something. It's only going to cause more issues. But anyway, luckily he got better, 50%. And what is the next thing wrong here?
Discharged.
Discharge. So the second golden point for young spine surgeons, what? Never discharge a patient who still got some symptoms. What are the three things that will happen? He is very unhappy when he is getting discharged itself. The highest chances he will not come back to you again. You are feeding the market to the another person, isn't it? So he will definitely go and get an immediate second opinion. And people like Naresh was educating me today morning about ChatGPT. So he will even put this in the ChatGPT, no? Operated 3 days ago, I still have severe pain and I was given an epidural. ChatGPT might say epidural must not be given in the immediate post-operative period. The chances are you have an hematoma, you have this, you have this, you have this. And then he'll come back to you? No. He'll go to somebody and then take an MRI and all. So never discharge a patient who is not completely okay. This is very important. Anything, even if you have operated trauma, if you have operated joint replacement, anything like that. So he was given and he was taken full weeks. And at 6 weeks later, that was the time we saw him first. So very severe pain of 2 weeks duration, very severe in the last 2 days, cannot turn or sit up in bed, and feels that there is a disconnection of spine at the operated site, feels febrile but no temperature. Now very, very characteristic of what? Discitis, isn't it? If they say, sir, I cannot, something is missing, I have to hold like this before I stand up. I feel as if the above and below is not connected. It's diagnostic of discitis. If you have seen 2 discitis in your life, then, you know, as the patient is walking in the corridor, you know, oh my God, this guy is got a discitis. Because the pattern in which they walk is very characteristic. They are very, very painful, and this. So, and this is also very true. You should not think that people with discitis have high temperature. They don't have high temperature. Sometimes they'll say, I feel febrile, but if you check the temperature, you will not temperature. Why is that?
Deeper tissue without much raised.
No, one important thing is, I'm not sure whether I'm right, but many of these discitis are not due to pyogenic, you know, our characteristic pyogenic organisms like staphylococcus or something which are highly inflammatory. They are many times due to Cutibacterium acnes, Viridobacterium, or some weird organism which doesn't grow in culture. That's why this terminology aseptic discitis came. They said, oh, this is a terminology called aseptic discitis because it is not growing in culture. But this organism is, there is an organism, but they are all very slow growing organisms, anaerobic, slow growing organisms, which does not grow in culture. So they have a florid local activity, but they don't have any systemic activities. But you should not fall into the trap of this terminology aseptic discitis. Why should aseptic discitis happen? If you think of logically, why there should be infection without germ? I mean, it is not there. So what will you do next? He has come to you.
We'll run some blood investigations and we'll
Yeah.
repeat an MRI.
So his ESR is 54 and CRP is
Raised.
28. So all the criteria for discitis are there. After some time, very severe pain, cannot move, feels physical disability, and then the ESR CRP must be high, because ESR must rise till 5th day. But in our scenario, I have found that many times the ESR keeps growing up to 7th or 9th, 8th or 9th day also, and then slowly only it comes down. Similarly, CRP also must come down by 5th to 10th day. But at 3 weeks, if you find ESR and CRP is high, then it is definitely not correct. So this is his,
Repeat MRI.
yeah, repeat MRI. What do you think?
This is a T2 weighted MRI with changes, signal changes shown.
This is T2. What is the other one?
Contrast.
No. So this is, this is very important, because you need to know to read your own MRI, because you send this to a radiologist, they will just write some edema found, query this, query that, and then there will be more confusion. Okay, so we'll go into that. So you see, this is the axial view. But what is very important is there is a lot of people who have claimed or doubts about the importance of immediate post-operative MRI in the first 2 months. They say that you take MRI of many normal people, they all have similar changes, and so it is not very, you have to be really a good person to see whether it is important or not. You send it to a regular radiologist who is reporting on liver, pancreas, who's a fetal radiologist, so fetal medicine radiologist, and then you suddenly show a spine MRI post-operative, they have no idea of whether it is normal or abnormal. So because many studies have said it is difficult from normal and abnormal findings, we should all know to read our own MRI. So how many of us know to read our own spine MRIs very thoroughly? Very less, isn't it? Then we are always at our mercy of our radiologists. So I'll just talk to you, sit down. I'll talk to you a little about how to read a normal MRI and abnormalities. This is very critical for that. Yes, please. So you should add whenever you want.
So this is regarding the previous. Whenever it happens to you revisit in your thought process, how did you start, inside, why it has never happened. Now, since there was an active brain there, just like in that everything, but still it on clinical exam, sometimes the tube is blocked, and find on clinical exam, you will have points there at the end of we always have this compression dressing post-operative body. It also stabilizes the muscles which have better things to do in post-operative. Now, to start with also like physiotherapy, you must learn how to give physio to a particular. All patients are not similar. In a case of severe lumbar canal stenosis, in a case of acute facial orthopathy, if you teach the patient, extensile exercises with movement, they will be worse. Okay, that is one. So all these cases you teach, because sometimes if you send to a physiotherapist of a medical college, you don't know whether the senior person is giving physiotherapy or a student, and sometimes they worsen, they come worsening. So for all these acute patients, you should know how to explain physiotherapy. I'm not telling you bed rest, total bed rest. In bed rest also physiotherapy can be done, just tightening the muscle. Interested in muscle wasting, okay, that you don't want, so that you can do. Now, even one factor which might affect that, sometime you leave the disc. You have actually digged inside and always try to correlate with the finding of the MRI. You had a large disc, but when you are opening, then you are not getting that much, whether it is left inside. Sometimes, with your action, it moves to other side or it is going down. So in MRI, as Professor Raj contributed, you should know to read the MRI. Sometimes disc is migrated down and you have not reached that place to take out. So in initial years of your life, this is very, very important. Okay. Thank you.
So if you are doing a post-operative MRI, we call it MRI reading. So you should know the patient, what he is coming for, what is his current problem, what is in your mind, and then you rule out by looking at MRI, just not a complete reading. So whenever you see the MRI, you must do it systematically. You should not take that 6 pictures and just look like that, just only at the sagittal view and take it off, because each view has got a very important reading. So you should know the optimal imaging sequences for each part of the sign and how to recognize the sequences, and what are you going to see when you see T1 and T2. I mean, they are meant for different things. So these are the 3 commonly done sequences. Previously it was only T1 and T2, but now still is completely, it's a very, very important this thing. The reason why it is here, how would you recognize between T1 and T2? The first thing to look at is the CSF. So water, CSF and edema is always black in dark in T1 and bright in T2. Okay, so water, edema and CSF is dark in T1 and bright in T2. But the problem in T2 is that you can see fat is both bright in T1 and also bright in T2. So T2 is the most, this is what all of us love. As an orthopedic surgeon, we don't like T1 because everything looks dark, and immediately we are asking, where is T2? Where is T2? Because T2 gives a better delineation, but there is a problem in T2. What? Both fat and fluid appear bright. So suppose you have a modic change or some changes in the bone marrow here, and there is a fatty infiltration of bone marrow, then that also looks white. Suppose there is a early infection and there is a edema of the bone marrow, that also looks white. So T2, although it can delineate very well the structures, cannot differentiate between fat and fluid. So that is why you need what is called a fat suppressed sequence. So next is, this is what is called the STIR, which is otherwise called the fat suppressed sequence. So fat becomes dark in this and only fluid becomes white in it. Okay. So if CSF is dark and the fat is white, it is T1. If both CSF and fat are white, it is T2. And if CSF is bright and fat is dark, it is STIR. So STIR is very important that you have to. So this is sagittal sequence, and then you will have to look at the axial sequence. So because the axial sequence is more, initially when you start reading MRI, sagittal looks more appealing. But actually when you start operating and when you start doing spine surgery, axial sequence is very, very important, because it gives not just the dura, but the placement and spatial orientation of the nerve roots, the nerve root itself going out, the fat around the nerve root, all the annulus over here, whether there is any inflammation, whether any perispinal problems are there, and you have a very good idea of the multifidus and the erector spinae. It gives a beautiful view of the whole spinal region. So axial is very, very important. So most of us see, 80% of us see sagittal,
50% of us only see axial very clearly, but only 20% of us see coronal. Yeah, because we don't search for the coronal and actually see. In fact, some of the scan centers, like, you don't get coronal cuts at all. But what is the use of coronal? So you can see any congenital anomalies, but actually it is actually in the coronal that you can trace the nerve roots very well. If you go to the next cut, you can see that the nerve root is going here, and you can see it very beautifully. You can see. So for seeing the nerve roots, you see the coronal. What else you see? Sacroiliac joint. Isn't it? It is so important to evaluate the sacroiliac joint. And next most important is you see both the hip joints. So your MRI reading is not complete if you have not seen the coronal sections, but only 20% of the surgeons actually see the coronal section. So you have to see that. Yeah. And this is a scout film is very important because it gives you a not only for the numbering, which is very important, but also sometimes you can have a schwannoma here or a OLF here or something which causes the pain. So you get a good idea of the whole system. So scout film first, sagittal, axial and coronal must be clearly seen. So what is the value of T1 sequence? T1 is for bone, T2 is for dura. So T1, because the bone is very nicely seen, for the alignments, for spondylolisthesis, for any shift and any other thing, you look only at T1. And also the marrow changes are very clearly seen in T1. Yeah. So you can see here, there is an infiltration of marrow very much over here. In T1, it is very clearly seen. Early changes of bone marrow infiltration are seen in multiple myeloma, lymphoma or metastasis is very clearly seen in severe sciatica. All clinical examinations are like sciatica, like a disc lesion, SLR positive, everything. And then in the MRI, we found that there is a infiltrating lesion in the retroperitoneum and completely involving all the nerve roots. So you should definitely see the coronal, very, very important. Okay. So normal anatomy, what will you see? So this is the vertebral body, this is the chorda equina, and this is the spinous processes, which we all normally see, but you should also be able to see the anterior longitudinal ligament. That's the posterior. That black thing you see over here is the posterior longitudinal ligament, and the annulus. That's the supraspinous ligament. That's the interspinous ligament, and that is the ligamentum flavum. So all these you are seeing over here is the ligamentum flavum. So all these you can see very clearly, and you must look at it in each of these. That's called the PSC. So that is the annulus, anterior annulus, nucleus pulposus, and the end plate. And you should look at the foramen very carefully. And at the level of the pedicle, you always see at the level of the foramen that this is usually a exclamation mark or a comma like. You will find the two nerve roots or one single nerve root, and then there is a lot of fat and usually a lot of space available for the nerve root. And that you can trace pedicle, neural foramen, pars. Pars you have to see, and this is the facet joint. So you can see that this is the two parts of the superior and the inferior articular facet. And you can also see the pars. If you look at the pars, you can see that there is a break here. Can you see? So you don't need a CT, but if you carefully go through the sections. The other thing is you should learn to scroll through the DICOM. Then you can easily find the pars defect over here. So this is the way over here. And in the axial section, you find the traversing nerve root, and this is the exiting nerve root. You can see that this nerve root is already exited out. And this nerve root you will not be able to see if there is a far lateral disc. So always the exiting nerve root is surrounded by a huge amount of fat over here. So you will not be able to see that very clearly. So if you are looking at the multiple sections, and this is this thing, superior facet, joint, inferior facet, lamina and spinous process. So you should identify and see in at least 50 or 60 MRIs, carefully spend some time, then automatically you will start seeing everything very carefully. Now this is a good pedicle, and then ligamentum flavum hypertrophy you can see very nicely. You can see this whole black thick thing is the ligamentum flavum, whereas in an ordinary patient this is the size of the ligamentum flavum, very thin, and it doesn't go into the foramen, whereas in this hypertrophy it goes right into the foramen, and also it's very thick. So everything specifically you must see. And look at the facets, because this is very important. This should be like this, very clean, smooth, no big fluid seen over there. But here you can see that there is a lot of, it's not very smooth, it's also got a lot of fluid inside, and this fluid here is also entering into the ligamentum flavum. It is beyond the facet and entering into the ligamentum flavum. That means what? There is a facetal cyst there, although it's not bulging, but in another position when the facets move, this fluid may get outside there and this thing. So you have to look very clearly, and also look at the psoas, multifidus, erector spinae, because in elderly people you will find all these are whitish in color because fat has completely infiltrated. So this is very important. So you can look at the nerves very nicely, and this is what I told you. You have to scroll between one pedicle to another pedicle, and then you will find both these. So this is the L5 traversing nerve root, and this is the L4 exiting nerve root. Now as you come over here, you will find that this traversing nerve root becomes the exiting nerve root. So you can see it's just coming, this is the pedicle. So this is going very close to the pedicle, okay? And in the next cut, you can see it has left it has come over here, yeah? And in the next cut, it has come over here. Always these exiting nerve roots are very close to the annulus, and also but surrounding a lot of fat is there, a lot of space is there. But then you can see, you can trace it even up till here. So if there is a far lateral disc, you will not see this very clearly, and all this fat will be completely gone. So then this S1 becomes now the traversing nerve root. As you go down, you will find that this becomes like this. So you can look very carefully at all these things. Look at the coronal images, and also learn to look for extraspinal pathologies. This patient has very severe back pain here. Anybody? You can see such very large lymph nodes, yeah, completely in the para-aortic lymph nodes are there. Here, you know, coronal section of the thoracic spine shows a lung lesion. What is this? Aneurysm, yeah. So all these things you should learn to look for yourself, then it becomes very easy. So that was useful. So this is, you should learn to look at the MRI by yourself. So coming with the background of that knowledge, now we have to look at what we are finding in our patient. Here you also have one more problem. You have to find out what is normal in the post-operative period and what is abnormal in the post-operative period. Now this is a post-operative patient, yeah. Lot of edema, some hematoma, some collection, everything is there. You can see here also the tract of your surgery is there. But what is important? That the disc edema and signal changes are confined only to the post-operative tract. Yeah? And if you look at this area where we have gone and made an annulotomy and gone inside, you can see that there is only a small lesion here. I mean, there is no big edema or big collection or granulation tissue over here. And this is what you look. find. So epidural soft tissue granulomas of surgery is confined to the disc areas only, and within the canal you find that nothing much is present. It can be unilateral, or if you are doing bilateral, then it can be a bilateral change. And there is a normal granulation you can see, and after 3 months you can see that there is a resolution over here, and this is also the normal granulation tissues. But this is an hematoma, but there is no surrounding inflammation over here. All the muscle plane which is next to it is completely normal. Although this is an hematoma, you do not. So when does it all become pathological? So what is abnormal here? This also looks like the previous scan, but if you have to look carefully, you will find that the edema in the disc, can you see here? The signal intensity in the disc is now filling the whole disc. It is not just in the place where you operated, but the entire disc has become completely fluid filled. And here you can see the whole of the epidural area is filled with a lot of fluid component, all loculated here, hyperintensity over here, and there is something more important. What is it? Anybody? Unlike what you saw in the previous normal one, this is the normal. Yeah. You can see no epidural component, no gross granulation tissue. More importantly, you look at the annulus over here. No inflammation, no edema surrounding the annulus. Yeah. Now look at this place where he has got a discitis. Everything is different, isn't it? This fluid collection is coming right into the intraspinal area. Lot of collections within the epidural area, and more importantly, you are seeing a lot of inflammatory changes all around the disc, in the peridiscal area also. So there is no doubt that percent discitis. Yeah. And in the early changes, you will find that, can you see, bone must not show any change. But now in T1, you see that there is a lot of edema within the bone, and you can see that this edema is changing into nearby areas also. So there is a florid discitis pattern over here. Change of bones and hematoma in evolution over here. So this is our patient now, 8 weeks now, and he has got, come, you tell me what are all the abnormalities you are noticing. Tell.
This is a T2 weighted image, sagittal section.
Yeah.
Showing L4 and L5 body in hyperintensity.
Yeah, there is hyperintensity of the body, and the disc shows.
This shows posteriorly and even anteriorly the signal intensity.
You have to say entire disc space is full of
infiltrate edema.
It is there.
Yes.
And here also the entire disc space is full of inflammatory changes over here. Yeah, this is very important, and you can see here a lot of fluid collection going outside. And if you look at the axial, it's very characteristic. Pockets of pus within the disc space. The entire annulus is inflamed. Normally the annulus is dark black in color. It's become white.
Even the flavum is inflamed.
Flavum, everything is there, plus also psoas muscle, adjacent psoas muscle, everything is now inflamed. So this is a very, very florid discitis. So we are doing a study on this, so a CT also was done, and you can see so much of erosions which otherwise you don't even recognize when you are doing a discitis. Yeah. Right. Now we need some bright idea. He is in front of you, a lot of pain. ESR is very high, CRP is very high. Now you have a 2-level discitis. If you had not operated on L3-4, which was probably unnecessary, this patient, you might have had only one level discitis. Now you have a young patient, 18-year-old, 2-level serious infection. So what are all the options, and what will you do?
Tissue diagnosis will always be gold standard.
Tissue diagnosis for what? Tissue means you mean it for histopathology.
Culture.
How will you do it? How will you get the tissue?
What post-op day is it?
This is 2 months, 6 weeks or 7 weeks, like that.
Open biopsy. I'll prefer open biopsy.
Open biopsy means what? Midline.
Through the
Anybody else? I mean, like, a lot of options are there. It's not like something is right or something is wrong. In different places, different things are done. There are people who will do endoscopic. Mic to you. Yeah.
So why create one more track?
That mic is not working.
Since this is severe pain and already shifted, I would like to fix and choose this stage.
Fix symptoms. Okay. Yeah, it's a very good option because these people have a lot of pain, number one, and then you can see that there is a lot of end plate erosions are there. So the question is that just like any other infected tissue anywhere, you would debride. So an open debridement is a very good option. So you get instant pain relief. So the pain relief that you see in these patients after doing a debridement is remarkable. I mean, the previous day they are crying in pain and the next day they are very happy. They all feel very much better because it is a closed space infection. And any closed space infection, there is so much of tissue tension that it gives so much of pain. And then if you do that, it is there. So anybody for endoscopic clearance, that is also reported very much in literature.
Probably the initial stages. The early stages maybe before 2-3 weeks. The initial stages probably is going to be decompression work, but now it's 8 weeks and already liquid changes are there.
Yeah.
So we need to address the instability as well.
Sudhir?
Typically also people are doing even with their previous type of picture there. So actually it can be done.
Yeah, spine surgeons are good to work.
I think I would not prefer an endoscopy in this case, though many are. Srivastava sir said they might be doing. I'm concerned about the cage which can get subsided because the end plate is already damaged. So I would do a fixation and facetectomy, complete debridement of the disc and send for biopsy and culture. 2 levels, yes. Yes, sir. No, yes, sir. Debridement, but not a cage, sir. I just prefer a isolate, just bone graft without the cage. We are doing since couple of years, and without cage also patients are doing better. Yes, sir.
Spine when there is infection, such florid infection. You will not do it. I mean, our mic to him.
We are doing such again another procedure. So is it all required to confirm the diagnosis and then what is the infection and control it before fusing it? Infection is not completely ablated. Is it really justified in fusing it again? There is a chance of even that fused part may be infected again, right?
So you can see here that there is an infection all around. So here, and all that. So if you are going to, we have published a paper long ago, 28 patients with postoperative discitis who were debrided, fixed and caged. No recurrence, everything is quite okay. This is actually published in Spine. But if you are doing that, it's very important that your debridement must be at a different level. So then you must know that you are not going to just go and remove a little and send for culture sensitivity and all that. So you have to remove the facets on both sides. This is very important. You have to put the screws, stabilize, but remove the facets on both sides, and then you have to completely debride. Yeah, like you have to do complete, more than a till. If you have to nicely debride, wash it out, make sure that you are very clean, and then you have to put a cage and then nicely press it so that it holds it snugly. So if you are doing that, you have to do it very properly. And if you use a microscope, it is very important, because through the microscope you can see very clearly. Once you remove both the facets, you can see the whole of the disc space, and then you have to take. Sometimes you will be surprised that big chunk of whole disc will come. Leftover remnant of the whole disc will come, and then you know if you have left it inside, it's going to be a big problem. Implants. They also do very well. Yeah. So that's what I'm going to come to the next question. When will you just debride? And so for this, we are great favorites of fixation. I mean, discitis means I always talk, because the dramatic improvement that comes in these patients after debridement and this thing. But this case, we were just thinking is only 18 years old, and then if we are doing this thing. So what we did was, we just did a microscopic double level bilateral debridement, just didn't fix it. We were just thinking we'll do all the clinical tests, hold the spinous process and move and see whether the facets have become loose and all those things. If it is there, we will fix it. We had consented the patient for fixation also. So it was not so bad. So we took a chance, and it grew Pseudomonas, appropriate antibiotics therapy, and this is at 10 weeks. Yeah, what do you see? I mean, the space is settling, but also that osteoporosis is gone. So it's all getting nicely sclerosed. L4, L5 is almost bone on bone is touching, but this thing is there, and this is him at 10 weeks. So it's completely back to normal, and this is him after 16 weeks post-op. So just as Sir said, you can also do a good debridement, and then you will find many of these patients settle down and fix or fuse by themselves. There will be a 12-degree kyphosis or 8 degrees kyphosis or 6 degrees kyphosis. That is only between you and the radiologist and the X-rays. Patient doesn't feel anything wrong about it.
Yeah, this query which is usually people have for this culture sensitivity and all this. Now he has some significantly acute failure to give away, and this is the surgical case. So instead of getting that, it is the right approach that we go and do the debridement. As mentioned by Professor Asik, nice debridement is extremely important. There you will know whether you have taken out everything or not. And what is pointed out, sometimes the annulus is remaining there, loose annulus is remaining there, and if you try to curate that area. Now all these cases, there may be severe degree of affection of the end plate. Now you judge. So once you put your curate, not vigorously to take out the whole bone, just gently you try to curate multiple times, up curate, down curate, curate, wash it nicely, and till the time you collect the sample, don't wash with the antibiotic. Okay, you take out the whole thing, that whole material will serve as your culture. Okay, so no need of doing, in this particular set of patient, no need of doing separate, taking out the material and sending further, and then you wait for the report. Sometimes you find such type of organisms, Pseudomonas, more so if suppose already once the procedure has been done, the more the chance of contamination also. So it is better to do that. Many people, if you have not done earlier any cage insertion or anything, you can put a nice bone graft. You can take out the strut graft from the, earlier we used to do pliff, not with the cage, with the graft. You shape the graft and you have to pack from right to left and you have to unite very fast. If there is a demonstrable instability, then you have to stabilize. Yeah. Thank you.
That is it. Sir, for that tissue, what are the tests you will send for that? Only culture or along with biopsy, gram stain, G-Lesion stain, like CBNAT?
Yes, we have also started sending it for fungus also. Fungus I somehow find is more easily identifiable in histopathology. So they always report on hyphae and other things present. And fungal culture takes a long time. So histopathology is for granulomas and for fungal, it is there. So we send for everything actually. That I don't send. We are sending for on-table frozen section for hip. So when we are doing a revision, if we have a doubt of aseptic loosening or septic loosening, so that as a routine, we always as a protocol send it for on-table frozen culture, frozen histopathology. But in spine, I have not used it.
It is. What is the next mode of treatment?
Able to grow the germ. So in that I'll give a broad-based antibiotic. So if you know the germ, if you know your enemy, half the battle is already won. But you have to be really become very careful. Many people say if it is not grown, they feel happy because they can show the patient, see nothing is grown, I am not in a problem, so there is no infection. So many patients who come with both sometimes total hip replacements, when they get infected, when they come for revision, they say, sir, doctor said there is no infection, he actually sent 5 or 6 cultures, see nothing has grown, so doctor said there is no infection at all. But all the time he is on antibiotic. So either it is that, or you are having germs which are not growing in blood agar, which is normally the agar that is used. So many of them are anaerobic, weird organisms.
The thing is, usually how long to give antibiotics and when do you stop?
Yeah.
Common practice here to give rifampicin routine. So your opinions on this?
So the world over, I mean, recently there was an ICM also, International Consensus meeting on spinal infections in Istanbul. One of the main questions that was asked was nature of antibiotics. So here we divide into two. So organism known, then you are on a strong wicket. If you know the organism with a clear sensitivity pattern known, then if you are knowing the sensitivity pattern, then previously we said 8 weeks of IV antibiotics. Some people even said 12 weeks of IV antibiotics. So now it has all come down a lot, and then it has come to 2 weeks of IV antibiotics, followed by 4 to 6 weeks of oral antibiotics. So if you have a oral component, like for example meropenem you are giving, and it has got a very good oral substitute also, you can give deonam, and the bioabsorbability of deonam is very good. Similarly, linezolid, if you are giving linezolid, the bioavailability of linezolid is as good, and the efficacy of oral linezolid is as good as IV linezolid. So in those cases, you can very quickly substitute and go to oral drugs. So 2 weeks of IV and 4 to 6 weeks of oral. If you don't know the organism, then it becomes a problem. Then you have to make 4 weeks of broad spectrum IV antibiotics, followed by at least another 4 to 6 weeks of oral antibiotic. Rifampicin, no, there is no science behind it, but you can use it, I think. We use rifampicin in chronic cases, but not in acute cases. Endpoint is you definitely we look at CRP. More than ESR, CRP is a very good blood marker. But you know, patient himself will feel so much better. It's the whole clinical condition that you will have to look.
In this patient, we have done a decompression. How do you decide the patient will do decompression?
Yeah, that's what I said. This we had actually, one of the 50% plan was to fix. But surprisingly, when we went and cleared, it didn't look so unstable. So I was a little bit worried to put 2 cages in a 18-year-old with a floating fusion, not leaving L5S1 and so we had also told that at a later date he might require this thing. But you know, this guy, as you might have seen the first time, he was in 2014, no problem. 10 years now, absolutely no problem. But obvious signs of instability, or if you have to do a facetectomy to clear, then you have to fuse it.
This much dysfunction of appendix, is it not an indication of?
This is a gray zone.
Here actually I would like to point out.
If he was a 45-year-old person, I would have fused straight away. Being just a schoolboy, I didn't want to fuse.
This is one of the advantages of so you are saying even though it is looking, so all categories is already gone. It comes to the very nice. For this antibiotic, we treat all spinal infections where no is affected and then optimum. So 3 weeks we gave we 3 months total oral. This is a recently expanded person is there. Actually,
yeah. Yes, sir.
We go down and describe it to them, or can you wait with the IV?
So I think you have found out the first few days. Yes, or first week, and in your MRI there is no big bony change. Surrounding edema, annulus hyperintensity, collection of, in this patient there was some collection all around outside and into the epidural space, I would debride. Now recently we had one doctor who has had an endoscopic surgery and he has come with the discitis, but pain only 4 days duration we took, and his ESR CRP is high. His MRI is showing very confined changes only. So we have started him on IV antibiotics. So your MRI picture also, like he very clearly pointed out, in this case is one extreme where we have not fixed, mainly because he is a schoolboy. But he was a 40-50-year-old man, we would have straight away fused and then it should have been. IV antibiotics in the first few days when the MRI is not showing big collections in the epidural space and in the peri-spinal area, then we will.
Moreover, if you follow the suppose you have admitted, he started his pain is totally spinal.
Is there any role of aspiration of the distal periods
in the early stages?
Do you practice them?
Yeah, but as a preference, we divide it into 2. So, like I said, very early stage, only 3 or 4 days, suspicion, CRP is little high, MRI shows early changes, we take blood culture, We don't aspirate it actually, but we start on antibiotics. The other ones we just go and nicely debride and do it. But there is definitely a role. I mean, you can aspirate and then send for the culture also. Definitely that is also possible. In about 30 to 40%. So just to get on with the discussion, this is the other case. So he is an engineer, a brilliant guy, has already got a MS position in Stanford, and he had low back pain and occasional left sciatica. This is also probably one of the cases where the surgery could have been avoided, because going into his previous history, he said he was very desperate to have something done because he was worried after going to Stanford if he gets a problem. So he was asking. But when again 3 weeks later, he has a lot of can you see here? Yeah. That is narrowing, because if you go to the previous, you can see this is pretty wide. And after the started narrowing, normally you sometimes can get a narrowing, but not within 3 weeks. And also you can see that they become very fuzzy. So IV antibiotics was started and AKT also was started. And it didn't work out. And when we saw him, this is the MRI. You can see really a lot of bone edema. There is a lot of completely the whole disc space is there. And 3 months he has been on different antibiotics. He has finished everything. Piptas for 3 weeks, linezolid tablets, AKT4 for 3 months, and he was in really a lot of pain, and he needed to go to US and take up this position very quickly. And because of this very increasing pain, you can see here again so much of destruction, and then you can see here retro, listhesis, instability, a lot of pain. And so we chose the other option of completely debriding, doing it facetectomy and putting in a large cage. He did very well. So the idea is to mainly, you can see after 1 year later, completely fused and completely stable. So both are possible, but you will have to be choosy on what is the time in which they present, extent of bone destruction, your MRI changes, and the amount of pain and the needs of the patient. So it's not like a very rigid, this, you will do this, it's not like I will always fix, I will never fix. Both can be done, but you will have to be doing. So anything on discitis, anybody has a doubt? Sir, by the time they have pain and they come to you, if they say I have severe pain for 4 or 5 days, if you take a MRI and you look at it carefully, scroll, you can easily differentiate between discitis and non-discitis. It can be sick because you see that there is a flare everywhere. There will be any. But discitis will rarely come in 4 to 5 days. In 4 to 5 days MRI you are doing to see whether you have operated at the right level, and we also take a look at to see, rule out other pathologies that you might have missed, and hematomas, CSF collections or large seromas, left back gauze pieces or anything. All other things you can look at it in the 4 days or 5 days within a week. Discitis comes only after 2 weeks. Generally after 2 weeks. They don't come before that. But by the time they come, you can, if you sit down with your radiologist and look at section by section, you can easily differentiate discitis from non-discitis.
Sir, in this type of fusions, you have to take the posterior iliac, we have to use the lamina material or spinous material. Correct. This type Case and bone graft. Local bone graft. Not posterior legs.
Not necessary.
Okay, sir.
Spine surgeons always take flexion extension view, sir, but general orthopedics is not suggesting that flexion extension views routine practice, sir. Yes, sir, 100%. Yes, sir. Is there any? If you don't take the flexion extension view, you miss.
You don't take miss a lot of things, especially stability. Sometimes you can find grade 1 listhesis. If you flex, it will become grade 3. So you have to get into the habit of doing, and also flexion extension view shows you vacuum sign very nicely. And when you do a extension view, you will find suddenly a lot of vacuum sign in the disc space. Vacuum sign is very nicely seen either in the X-rays or in the CT, but not so very clearly in the MRI. So in the MRI, you might miss vacuum sign unless you look at stir very carefully, or there are other sequences called flash sequence. But you must do this thing. When you do an extension, you will find many of the pupils are also having an instability, retrolisthesis. So you should do a flexion extension. So in our hospital and in many hospitals, if you write X-ray lumbar spine only, we write. So normally they will do AP lateral straight flexion extension. Yes, sir. No, it's not necessary. It's not necessary, but it will show you dramatically how much bone is lost, and you will be surprised that more bone always looks lost than this. The other reason you can do CT is that if you are going to put in a lot of cage, now completely the end plate is lost on both sides, then it is better to avoid a cage and pack it up with a lot of bone graft. So to assess whether there is any leftover of the end plate also, you can do a CT. Otherwise, it's not. For diagnosis, it is not necessary. But for surgical planning, it may be okay. Is it? This was all T-leaf only, is it? That also you can. I mean, but yeah. It's how you want to do it, how well you are doing it. But coming from behind, it helps you to go on both sides and debride. But if you are going by Kamin's approach, the other approach, then you are approaching from one side and your visibility is only in that channel. You cannot take the whole thing. But here it allows you to go from both sides and do a very good debridement. Yeah. So I am just showing one more case. We'll go through this fast because it just reiterates all the principles, and also on the possibility of you should not worry about putting a metal inside the infection. So this is a 52-year-old male, diabetic 6 years, right L5 radiculopathy for 3 months, normal neurology. This patient also, we saw him very late. So you can see this is a very good example of how things can go wrong. If the patient has got bad stars or the surgeon has got bad stars. So this is very straightforward, isn't it? I mean, huge pain, more than 3 months, and nobody can blame the surgeon if he has operated. A laminectomy was done and discectomy has been done. So this is what has happened. So patient developed severe back pain 1 month after surgery. So radicular pain record. No fever and constitutional symptoms. So he goes to local medical college. So the local medical college does an MRI, and what do you find here? Massive infection, isn't it? So here if you see, whatever we spoke is there. So the disc edema is throughout the space of the infection, even anterior to the anterior longitudinal ligament, ALL, large epidural collections, and these epidural collections are seen on granulation tissue on both sides of the in the epidural space. The whole disc space is hyperintense. You cannot see the normal dark colored ALL at all. Annulus is gone, and a lot of peri-disc infection, and you can see that the psoas is also pushed. Psoas muscle is also highly inflamed. Your paraspinal muscles are also highly inflamed. So this is a very fulminant infection. It's not only discitis, as you say, more like the entire tissue, pan tissue infection. So diagnosed as discitis, and in the medical college they did a debridement and decompression was done, and culture showed no growth. Symptoms persisted after surgery, so the surgeon started him on ATT also. 3 months later, MRI repeated as pain has worsened and patient developed deficits. Now he has got right L4 and L5 as grade 2. So there is an ongoing problem. So this is the so what does it show? Much better than before. Yeah, much better than before, but still there is a lot of activity, and you can see that there is a large, very big granulation tissue on the right side, which corresponds to the side where he has got a deficit. Yeah, and more surprisingly, what other investigation is required here? What is missing? Most important is a plain X-ray. So never order for a MRI without doing an X-ray, because the X-ray shows a global picture of what is happening. So now you are getting alarmed, isn't it? Something massive is happening here, because you can see that this place is completely unstable, facets are gone, there is some subluxation. If you are seeing, that's why all views are very important, and this you see, you may think, oh, it is all settling down and it is looking good, it might fuse. When you see the AP view, you know it's not. I mean, something terrible is happening, a lot of instability is there, and that's why the patient is having pain. What is the best method to treat now? So fixation is definitely required, isn't it? I mean, otherwise, in this kind of instability, just as we know in long bones, stability is required for infection clearance. Even in TB now, we know if there is a gross instability. Stability, you give stability and give AKT, the TB goes very fast. You don't give stability and the patient has got instability, you give AKT. These patients take a long time, not only to become asymptomatic, but also to get cured of TB itself, it takes a long time. So stability is very important for infection clearance. So for some reason, they decided to do an anterior debridement. Okay, so an anterior debridement, the note said anterior debridement of the L4-5 space and ileal crest grafting done. And now, for the first time, they were able to get a Pseudomonas this. So started on sensitive intravenous antibiotics, and ATT continued. ATT is continuing. I mean, it's going on as a support, moral support for the surgeon. So it's just going on that continuously. And you can see that this is, I could get only the lateral view. You can see that there is a graft here. Can you see? But that is also sort of extruding out. AP view is not seen. Patient's pain improved slightly, but again worsened with severity. MRI was done to assess healing. So this is it now. So worsening deformity, extending infection, surgeon advised bed rest, ATT and review later. But also their notes said in view of the fulminant infection, stabilization was avoided. Correct or wrong? Wrong, isn't it? In fact, it should be the other way. You should provide stability. Otherwise, you see, because of instability, is getting worse and worse and worse. And you can see that this patient, now what is happening? So he came with L4-5 disc. Now he has got L5, here also hyperintensity, here, here, here. So L5, 4, 3 is involved now. And large epidural abscess, and he's getting a neurological compensation. So he came to us like this. Okay, 10 months post-op. 10 months had gone by this time. Not walked for 6 months, severe back pain, right, uncontrolled diabetes, albumin 2. This is CRP was 2,206. So all really bad scenario. So what will you do now? So if you look here, there is still more bad news. So this is 5, 4, 3 also is involved. Now L2-3 disc has got fulminant discitis, and the epidural one has gone up to L1. So what started as a L4-5 disc has become spondylitis from L1 to L5. Yeah, and this is what he started with. Massive, isn't it? I mean, you have to see that things can go wrong, then it will go wrong terribly. So you can see a lot of psoas edema, collection of fluid outside, everywhere. Now you can see here at L4-5 and all, the psoas also is very highly, a lot of fluid, everything is there. And this is the X-ray. Definite reduction of disc space between L3 and L4, and the L2 and L3 also, there is a lot of complete destruction. So what should you do? So you should no longer wait for stabilization. Huh? I'm just showing this mainly to say that you should not hesitate to give stability to the patient, or stability is 100% necessity whenever the patient is having a spinal infection. So this is also a very old case. So this is what we did, and then he went on to heal completely well. He had pseudomonas, and then in 6 months' time he had a complete functional range of movement. So the whole idea is that if you're, what is all the learning points? If you have discitis, very early stage, antibiotics is enough. But if it has become pan disc, annulus, everything is showing involvement, a lot of fluid collection in the psoas, epidural granulation tissue is more, a lot of instability is there, very severe unbearable pain, then you would definitely debride, and then you decide upon fixation or no fixation depending upon this. End plate is intact and you are sure that it will withstand a cage. Cage gives an instantaneous pain relief and stability. But if the end plate is grossly gone and you are into soft cancellous bone on either side, it's much better to put bone grafts rather than just this. You can take a tricortical iliac crest graft nicely and put like 2 clips inside and then jam the thing, then it will be very helpful to reduce the disc space as much as possible. So you should not leave a dead space over there. So you remove facets on both sides, and then when you squeeze, you will find that you can reduce such a large disc space into such a small one, and then the bony healing takes place much faster. And in the presence of instability, and often this instability is more clearly seen in AP view than lateral view, then if there is a translation like this, then it means that the facets are also incompetent. That's why you can get a translation. Or there is a gross rotation like this in AP view. Then these patients require a fixation at the immediate point. Yeah? Yeah. Whenever you think the topic is getting boring, we can move to the next topic. Yeah. What is the cause of discitis? Yeah. Yeah. Yeah, that might have been instability before itself. And that brings to the question what he asked, would you do a AP lateral? So if you have missed a existent, already pre-existing instability, you're only going to make the condition worse. In the post-operative period, normally we don't do it unless they have a problem. I didn't catch the question, sir. So you have done a discectomy already. Yeah, huge disc, yeah. This unfortunately had a infection. Otherwise, they would have escaped and come out slowly. In young patients, large disc space and a huge disc bulge are all very poor prognosticating factors. And also, if in the MRI you don't find much of disc degeneration, you still find that sandwich burger type of appearance in the MRI in T2, and he has got a large disc with a large disc space, young man. It's one of the worst cases to do. They all have a lot of pain after that, and they don't do that. Yeah, if it is a very huge disc, we also sometimes discuss with the patient that they may have a back pain. Although we may not do it initially, we definitely, you have to counsel the patient.
Sir, first surgeon started ATT. We diagnosed it, we have done the culture for Pseudomonas. We have to continue ATT or we have to stop the ATT?
I think we can stop ATT. But you know, the Pseudomonas that was grown was in the third debridement.
Okay.
So till that time, everybody said, okay, he has been started at the full course, gone. But there was no reason to do AKT here at all. We could have stopped it.
Not regarding the case, sir. Present scenario, ATT tablets are not coming into private pharmacies, to only available in government hospitals. They are using the DOTS regime. For skeletal tuberculosis, how many weeks or months we have to give this DOTS regime, sir? Is it useful?
Now, DOTS regime came for spinal tuberculosis quite a lot, but our experience was not so good. They took a very long time to get all right. So we have completely gone back to the same 2 months intensive regime, and at the 6th month I take a MRI, and so we see the clinical improvement and the MRI ESR, and then we decide whether to continue more. So I don't give ATT more than 8 months in any patient.
This DOTS regime is useful,
sir? We have given a DOTS regime. I don't know what's your
these
opinion.
drugs are not available in private, sir.
Why we are having private? We are having it in our hospital. Yeah, DOTS regime is not good. So you have to go back to the intensive phase and continuation phase.
Total together 9 months.
I give for 8 months, 7 or 8 months I give.
Okay, sir. Thank you, sir.
Sir?
Yeah. Yeah. I think the first surgery, the whole problem started with the infection. So once the infection takes place and then it involves the bone also, then destruction, then the annulus all gets completely smudgy, then the whole thing becomes completely gone. How to prevent discitis? Okay, so there are a few predisposing factors for discitis. Come and tell one. Comorbidities. I mean, if the patient has got diabetes, chronic renal disease, they are highly prone for smokers. All these three are very important. Now in most of the American hospitals, they are all checking them for blood nicotine. So patients will come and tell you, I am not smoking, but they have a lot of smoke, so they will check for this. So other than comorbidities, your handling of the equipment is very important. So if you are an open surgeon, then you will have to make sure that none of your instruments actually touch the skin when you are getting into the disc. If your disc punch and your upcutters by mistake they are touching the skin here there before this, then there is a higher risk. If you are using microscope, always when you get into the first 50 cases of microdiscectomy, then again your incidence of discitis becomes very high, because you are touching here there, and this is so sometimes your equipments, your instruments touch the microscope. The whole, and it is not enough if you have just kept a formalin tablet or something. You have to drape it with a nice plastic this thing. However much you drape, whatever you drape, that last bit of the lens, that huge lens, question? Sorry, sir? Yes, sir. Okay, let's divide it into three. One is fragmentectomy. So you are just removing whatever has come out, and you will not go in and take anything. So this was very popular before, called the fragmentectomy. And then they found that the recurrence rate is very, very high. So that is out now. So you have to go and remove some of the disc. The other extreme is going and aggressively removing a lot of disc and also curating a little bit of end plate. That also was a disaster, because they found when you do a very aggressive discectomy, your rate of discitis is high, and also post-operative pain in these patients are very, very huge. And many of these patients got a list like this in the post-operative period, and they had a lot of difficulty in walking, and they settled only after a long time. So now it is called conservative discectomy. So, and how much you remove will depend upon your psychomotor, your hand, your feedback. As you are removing, after some time you know you have removed sufficient. And then we put a thick feeding tube and give a good wash, then again try to remove all the pain. So conservative. Sudhir, what's your opinion about this?
Piece which has come out and only any piece inside the loose piece inside the bed. You need not take out all the fibers. So that will, as Mr. Raja told, don't curate it. Curating should not be done. Rather, you should do probing.
It's okay.
So probing and all the loose disc you should take out so that there won't be recurrence. That is important.
If you have body changes on your MRI, like do you warn the patient like chances of discitis and what is your course of antibiotic post-op?
We have not changed our antibiotic regimen, but we instill intradiscal amikacin. And in these patients, we don't do a very aggressive discectomy. Definitely no curating and other things. The small zone is not associated with the body change around the small zone. So only when there is an aggressive body change, if you want after I'll give a short presentation on body change. We got an interest about.
Regarding this, how much disc to remove? I think it's a good habit to correlate the amount of disc removed to the MRI changes, and this to see if both are matching. If there's a huge disc on MRI and if you get little material, maybe you have left something behind.
But more than how much disc you are removing from inside, it is important to know whether you have removed all the disc outside. So you have to, before you go for surgery, you have to look at your MRI very carefully and you have to clearly have an idea that this disc has come out at this place and it is going down. So inferiorly migrated large discs, if you are moving the nerve root and seeing, sometimes you will miss it because the inferiorly migrated discs are present in the axilla. And the superiorly migrated discs are present in the shoulder. So whenever you have an inferiorly migrated disc, you must probe into the axilla also, and suddenly you will find a big piece there. So you have to be careful about that. Okay. Yeah. Okay. Yes, sir. Chances of meningitis, huh?
There is any repair of
this patient. I mean, you are ahead of me by one slide. This is exactly the patient we are going to talk about. So 26-year-old, severe left-sided sciatica, 4 months conservative treatment, failed SNRB. Okay. So this is the picture. So anybody will raise an objection if this was operated? Straightforward, isn't it? I mean, very large disc, severe sciatica, 4 months period, SNRB has been tried. So no issues regarding that the patient requires a surgery over here. So this was also done outside. Open fenestration discectomy was done. That is not a problem. Surgery was uneventful, but after the patient presented to us, I actually talked to the surgeon. He said during the surgery, I had a doubt whether at one point of time there was a small leak. But then I asked my assistant, did he notice it? He said there is no leak. And we also tried probing. There was no leak, but doubtful, sir, he said. But stopped after some time. So this patient did not go back to that hospital, but he had a very large, some fluctuant mass over here. And the reason he came was, so one of his friends came and tapped his back. How are you? And he felt a shock in his cranium. He said, I had a shock, something, a weird feeling in my shock. After that, I asked my wife to tap. Every time she taps, I am getting a shock in my cranium. I have a weird feeling. And then we saw he had a bulge. Just on the operated side, there was a bulge. That's something that we never like to see. Yeah. Okay, man. You only asked about it, so read this. Yeah, but you shouldn't say like that. You should always.
This is sagittal section of T1 weighted, T2 weighted, and fat separated MRI, showing a large cystic collection over the operated area. Might be a pseudomeningocoele.
No, man. Only 20 marks. You have to read the MRI. So much we talked about reading the MRI, and now you are just. I am saying this is pus. I am saying it's hematoma. So what do you say?
So
you have to tell me why it is not hematoma. You have to tell me why it is not hematoma. You have to say why it is not seroma. What else is there? CSR.
Regarding pus, sir,
Yeah.
inflammatory changes around the cystic collection and the disc space or any epidural collection.
Yeah, so if you see here,
loculated.
It's a very thin layer, isn't it? So there is no thick. The wall of the collection is not very thick. It's very thin. It's very nice. It's very clearly defined, and there is no inflammation. There is no inflammatory signs. The surrounding muscles here and all, you can see that there is no inflammatory reaction at all. If it was pus, then it is thick walled. It is very, you cannot see a very beautiful differentiation like this. It will be very hazy, and there will be surrounding edema of the muscles. So hematoma.
Submuscular seepage.
No, why it's not hematoma or CSR?
Compared to the CSF, it is looking.
Hematoma is plus on both T1 and T2 in the early stage. And also it will not be so homogeneous, there will be some clots here, some clots. So it becomes lobulated and heterogeneous, this thing over there. But actually you are missing one very important point, which is striking on the face.
Connected to the dura.
So you have to always go through each section to see whether there is a connection between the dura and here. So if you see here, there is no connection. Yeah. So if you see this section alone, you will think this is not a connection. Though when you go to the next section carefully, if you see, can you see here it is connected? Yeah. And what is this? There's like a fountain coming there, no? What is it? It's called the flow void. So when the magnetic resonance is happening, one gush of fluid is coming inside. So this is called the flow void. You can see CSF from here is gushing into this thing. So it is called the flow void. So if you see this, there is no doubt it is pseudomeningocoele. This is a very important sign that you will have to look for in So this is here. Again, you can see here there is a flow void. CSF signal void is seen here. That is the signal void, and this always is found at the level of the connection. So that is a visible. So whenever you see this fluid, then this is, you have to put it into your mind. So fluid and edema is dark in T1 and bright in T2. That's how we differentiate CSF T1 and T2. Blood is in the initial stages. It is bright both in T1 and T2. So third day or fourth day you take, there is a large hematoma. It will be plus plus. CSF is again like fluid. So T1 it will be dark and it will be bright in T2. Fat is of course going to be bright. And abscess again is down in T2 and up in T2. But not only this, there will be surrounded inflammatory tissue and the margins are thick and irregular over here. So with all this, it is actually it points to, and moreover we have the flow void. So that is actually a CSF. So what will you do now? So anyway, that requires a opening up and finding out where it is there and closing. But one of the most important thing is that how many people think that CSF leaks are deadly or it is okay? No, of course. So if you have a CSF leak, would you lose your sleep over that or? It depends whether you're talking to a neurosurgeon or an orthopedic surgeon. So if you're talking to a neurosurgeon, they'll say it's not so bad because they're all the time having it, but they will make sure that it is sealed. That's the most important thing. A CSF leak, you create a dural injury, but at the end of the surgery, you have sealed it. Then it is nice. I mean, there is nothing. I mean, it's like no problem. But if you are leaving a CSF leak without sealing, then it is like this. 90% of the cases settle by itself, but 10% of the cases they give problem, they'll give massive problem. So if you have a CSF leak, you have to spend time to make sure that it is completely sealed. So in this, I'll spend a few minutes and maybe everybody can pitch in also as to what. There are many ways in which you can use to seal. Huh? So that's why I put a stitch in time saves a life. I put a life because many of these patients can get infected, meningitis, and then it becomes life-threatening. Okay, sit down. So what is the most classical way of sealing? Is by stitching, isn't it? So if this is the dura, you can see this is the pars intraarticularis and the facet joints over here. If you are very lucky to have your cut here, nothing like it, you are very lucky, isn't it? You can just go ahead and stitch it. The whole problem comes if when you are taking a bite of the ligamentum flavum here, you create a problem at this area below where you are not able to seal it, and then it becomes a big problem. So if you have a dural tear like this, let's see what you can do. That's a straightforward area where you can stitch. So you can see that the arachnoid comes and closes it. So sometimes it will look as if it is not leaking, but you should not get fooled because after you go, it will start definitely leaking. So the standard method is to make a stitch, and you need, if you have a microscope or a loop, it is important. It's very difficult to stitch without a, you have to see the, wait a minute, I'll just show you. This is the most important thing. So yeah, when you stitch, you should see your needle here completely as you saw here. Can you see the needle? The full stretch of the needle. Why is it important? It has not taken out any of the nerve root in the bite. So you must see the, this is the most, that's the reason I put it here. Second principle is, this actually requires 2 stitches. Yeah. So if you do the first stitch and then you tie it off, then it is very difficult to put your second stitch because now you can see through the tear. But once you have closed half of it, you don't know where you are putting the needle and taking it out. So you should never tie your first stitch completely. So let's see what we are doing here. Yeah. So you don't tie it, you leave it like that and take the other stitch. Yeah. Now you can see the needle still there. So now when you're taken, then you can cut this into two, then they become two different, and then you can easily put your second stitch. But if you have first put your first stitch, then your second stitch becomes very, very difficult. And also one of the most commonest mistakes we do is we take the first stitch in the center. And then you have two small things leaking here and here. So you should take the first stitch this side and then this. So once you have these two, now you see it's very easy. You can tie both, then it becomes okay.
30 silk?
No. Minimum 5 or 60 silk. Not silk, proline. So now you see it's easy that you close it by 2 stitches. But if you have taken one, and the worst thing is to take the first stitch in the center, then you have very little space on this side and this side to do it. Yeah. So this is one method of doing. And then you have to do a Valsalva, and if it is not leaking, I always place a Duragen above it. So the Duragen actually sticks over that and nicely forms a good layer. So it's a protective layer, and once you are nicely closed, your Valsalva doesn't show any leak, and you have kept a Duragen and you are closed without a drain, you can mobilize them as you do for anything else. So there is no problem. So this is the best way. If you are lucky, if you are in the center, this is the same. Now what happens if it is in the corner? So this is a micro discectomy. Yeah. So you can see this is the center. This is the center, and this is the ligamentum flavum. This is the facet joint somewhere here. So the whole of the ligamentum flavum is exposed, and while it is being exposed, the cautery, the cautery tip has pierced the ligamentum flavum here and gone inside, and then it is leaking. So this is another different situation. Yeah, so we'll see what to do. Now the most important thing is, if it is like this, don't stitch your dural tears before you finish your surgery. So if you have to do a discectomy, or if you are doing a TLIF, you keep the area where you have the leak on a patty or something, you keep the Duragen, and then you finish the whole surgery and then only stitch it in the end. Otherwise you will be pulling and pushing on. So we are actually extending under the microscope. So we are making a, that is the ligamentum flavum. And below that you can see there is the leak. So I'm just excising the ligament. Normally we keep this as a flap and then do the discectomy, but in this case, because so so that is the annulus. You can see there is a very big, very large disc prolapse. That is the nerve root is here. I'm just doing a small annulotomy. And as soon as you do the annulotomy, the whole disc is coming out. So all this you should finish before doing your dural stitch, because after you do the dural stitch, you are pushing your dura this side or that side, it can happen. And in dura, you have, I'm just going fast forward. So all this is So you're now happy that you have finished. That is the anelotomy, that is the nerve root. You can see that the nerve root is inflamed because of chronic pressure, very mobile. And now you come to think of what to do for the, now this is hidden inside the bone. What can you do now? So there is one more trick, that when you have only limited access, then you have this small titanium clips which you have that. Wherever your needle is not going into that, you can't actually put a needle into that space at all. So you take that up and use your titanium clip. Yeah, it actually makes your job. Otherwise, this is such a big problem. You have to do a complete fenestration, widen it, and then go. Your microdiscectomy has to be converted into a open discectomy and all that. And you see, this one is such a nice quick fix. Yeah. See, it's so easy. Yeah. So this is the third situation that you can actually do it. And this is actually a cervical myelopathy where we have done a laminectomy, the instrumental laminectomy, and then you have got a leak at this end. You can see that there is a small tear here and there is a leak. All the more important in cervical spine that you don't leave a leak. Otherwise, this is a high flow area, they'll form a myelomeningocele, and then so again not stitchable because it is right underneath, but that area fully you have to plug it with fat that you are removing from here. Put it through the tear itself so that it seals well. Because I'm going to put tissue and I don't want to put tissue directly over the torn dura. So once you do this, then you can seal it off. Over the fat, you can put tissue and then it completely seals off. So wherever you have problems of, this is the same thing. And this is, you can see completely the whole dura is gone and all this thing. It is 10 days old trauma case. So where when the laminectomy was done for this thing, there is a big post-traumatic tear. You can see there is an irregular post-traumatic tear and all the nerve roots are pointing out here. So in many of these post-traumatic tears, it usually looks as if there is no dura to repair. But if you carefully see that and gently you work it out, you can see that there is this is irregularly torn, and the dura, because it is a little, about 10 days, it is very thin. The nerve roots are all swollen, cauda equina. So they are bulging out, but you pack it with the patty so that the nerve roots stay inside, and once you do it, you put a clip. But then we thought it was good, huh? So we did a Valsalva and there was a gush of CSF. That means you can see here, there is another secondary tear here. That is not stitchable because the dura is very light, and so again the same thing through the tear. I am just parallel packing. And once you have sealed it, then you can put you can't put the tissue straight over there, because as soon as you put the tissue, the CSF will come and wash it out. So you need to have a firm closure, no CSF leak, and then you have to do it. So that is the same thing. And this is a case where I'm just showing different methods in which you can. So this is a revision case. You can see that there is a thick fibrous tissue completely over the dura, and there is a dural tear over here. So you have to delineate the dural tear completely. And then we found that the dura was so thin that I was almost 100% sure if I take a bite and then pull, it is going to tear. So you take fresh fat. All other sealants have cost a lot, not fat. So easy available. You can see a lot of muscles are there. I mean, nerve roots are seen. You cannot put tissue directly in that place because all the nerve roots are. So you just pack it fully. Then over that, you keep a Duragen. Yeah, and over that you can suture this scar tissue back, so it holds the Duragen and the this thing back. So you can see that once you stitch it back, then it holds the Duragen and the fat, this thing over here. So that is the way that. So it was also debrided. It grew E. coli, then the dura repaired with fat graft, Duragen and tissue, but it just settled by itself. And this is it. After 12 months, no problem. Yeah. I hope this was useful. You have to be careful that you don't leave a leaking dura at the end of the surgery, because it might settle or it might give you the maximum amount of problems. Yeah. So, did anything you have to say? So, protocol, post-operative protocol. If you have nicely sealed, Valsalva maneuver negative, then as normal. So, but if you have done a critical repair and you want for some reason protection, we keep them in bed for 2 or 3 days and then make them walk. Upper cervical area, if or in the thoracic area, if there is a leak, we are not very confident of the repair, then we put a lumbar drain. Diamox also we use. Diamox, lumbar drain, some bed rest.
Yeah, almost similar protocol. If it is stitchable, you must stitch it. Sometimes we have a lot of cases of ligamentum flavum ossification, and practically the dura is ossified. And you come to know it even prior to your patient taking to the OT. So for that, you have to be mentally prepared what you are going to do. So in that case, you thin out the whole thing and then you start from the periphery. What happens? All these central part, usually it has a space from the lateral gutter. So many a time you will be able to take out without much blood. But if there is sometime it comes out with the and you have a large defect, there you have to use the fascia lata. We use fascia lata, try to stitch. If it is not stitchable, in that case again the same, put a fat. We also put muscle, it is mesh muscle and which is kept on that, and on that you put the gel form. We always put the drain, but we never charge the drain. Important. We always put the drain, but it is dependent drain. It will be lower to the cot of the patient and give a very good suture. The whole of the fascia, lumbar fascia, muscles, each layer has to be reached very well, and then we give compression dressing. And almost all patients become all right. There is no problem. One complication we had, there was a air collection in the cistern, pneumatocyst you can have. And patient start having headache. And you must be very, very watchful from that. Most of the time, that patient which I had, he also settled. We took opinion of the neurosurgeon also, he settled. So that is only one case we had that problem. And the leak was there for almost 9 days. But it settled gradually. There was no shift. If there is a midline shift with that air collection, then you will have problem. So that care is due. From the beginning, you have to be careful whether it is a small leak or it is a large leak. As Professor Asekran told, lateral gutter leak is really problematic, and you have to actually do all those techniques, putting fat, putting muscle, and all those things. And main thing is then you must take a proper precaution post-operative. Okay, you have to give a real good compression dressing, and drain we always put, though suturing is very tight, but it is a dependent drain, and many times they heal very nicely. We don't have any problem with that.
Sir,
the puncture wound, but it will not go back. So neurosurgeons sometimes say it doesn't cause any problem because they are always used to excising the whole dura for meningiomas or for tumors and all that. Then there is a big patch which is lost, it is okay. For that, as Sudhir said, if you nicely do a watertight closure, after some time there is a small CSF collection, but it stays there. Because CSF comes, goes, it is in connection with the main flow. So there is no extra pressure. But if you have a punctured wound or a small wound, it is the most dangerous. Because with every cough, sneeze or breathing, little CSF will come out, but it cannot go back. So it acts like a valve. Oh, 100%. If you have difficulty in closing, even extending it a little bit and suturing is advocate. No. So you are actually going to lay down the fat, but you are not going to. Fat, you cannot actually pressurize your fat at all. You can't pressurize the fat, whereas you can pressurize Surgicel and Abgel. And that is why when it is there, you should never use Surgicel and Abgel, because it is in your enthusiasm to block, we will be pressing more and more. And also they have the bad habit of absorbing blood, and they will expand and then solidify it. But fat, you cannot compress fat. So fat is a very, very safe thing to pack. Yeah, we'll go to one more before we go on to the oration. Yeah. They need a coffee break we'll have now or later? So this is a quick one. So yeah, 11:30 we'll go for a coffee break. Yeah. So this is a 62-year-old man, low backache, bilateral radiculopathy, increased severity, claudication, known CKD on analysis. And when he landed to us after 3 months, so this is the X-ray. So this was marked as large disc prolapse of L2-3, operated and fixed. So he was in a lot of pain and severity. You can see that there has been some wrong work. I mean, the screws are okay, but as soon as you see, it doesn't look very symmetrical and it's not aesthetically placed, but I think there is no problem with the screws. It's more important that it is in the right place than to be aesthetically good. And a lot of pain. So an MRI was done and it of course shows infection. Yeah. So infection because the soft tissue collections are extending well beyond the sites of surgery and they are tracking up. You can see even muscles above are much, and here you can see there are collections and signal intensity change going through and through up to the front. Anteriorly also there is some pressure and some collections over there and large epidural collection over here pressing the dura. Here also you can see that in the axial views beyond the confines you are seeing lots of collections in the all around the disc. Psoas muscle also is very highly inflamed. So 100% infection. So this is an instrumented infection. So what is the best method? Leela, you are the best person for this. Tell. So number one, how many would treat it conservatively? Anybody? No chance, isn't it? I mean, he's an old man, a lot of pain, CKD, and especially people who have got chronic morbidities and medical conditions. Previously, we used to think we should not operate because they have medical condition, but now we know if you don't operate, they die much faster and they have a little immunodeficiencies, all of them have, so you need to help them with debridement. So no conservative treatment is one. So I'll also help you with a CT.
Axial images, sir.
Axial view also, okay.
So I'll do a facetectomy and thorough debridement of the disc space, sir.
Yeah. And
I'll check if the screws are loose.
Yeah. They don't look like loose, but we have to check definitely.
Intraoperatively loose. Do a laminotomy, thorough debridement of the disc space. Put in, pack in graft, autograft. Then if screws are okay, I'll try to retain them, sir. And if screws are loose, I'll exchange the screws.
So you can see now, unfortunately, the bone destruction is quite huge. Huh?
Yes.
So here almost half of the 50% of this is completely gone. So it is always a problem if your bone defect is like this. So where it is narrow on the side you are operating and it is open away from you, then packing the bone graft or even putting a cage or anything becomes very difficult because there is no. If it is opposite, if it is more broader towards you and it is funneling out on the opposite side, you have a chance to put a cage or you have a chance to put a cage. So that you can see all these things, what they have put in is gone outside. It's very, very important here. So here, one of the most important thing is when you are doing a debridement, So it's not very clearly seen over here, but you can see the vein here. Can you see? The vein is coming closely opposed to the body here, and then it is going like this and then coming back again here. That means all these stuff is very, very close to the vein. And if you are picking up with your disc punch, you have to be extremely, extremely careful, otherwise you can pick up on the vein easily. So it is actually a very risky, tough case, because if you don't dip, it's not going to become your aggressive dip, right? You are at risk of injury. So in these cases, it's very important to have a microscope or a headlight with loop, so that you can actually look down, very carefully scoop out without hurting the main vessels. This is very important. So how many of you use a loop or a headlight or a microscope? I think if you are going to do serious spine surgery, you must get one of them important. Microscope is expensive, but it is versatile. You can use it for anything and everything in spine surgery. But if you are not able to afford, nowadays good microscopes cost in excess of 75 to 80 lakhs. So, but otherwise a headlight and loop is very cheap, but it can use the same thing. Only thing, when you are using the loop and headlight, only you can see what you are doing. Even your assistant cannot see what you are doing. And because you are always looking like this, your head is coming on this thing. The assistant gets bored after some time, because he can't see what you are doing. Even if you are doing discectomy or even if you are doing ACDF, only you know what you are doing. So the whole theater is bored and you cannot teach. Whereas if you have a microscope and a screen, everybody sees what you are doing. So you cannot say simply I have debrided fully, because everybody, including the anesthetist, knows you are bluffing. Something more is there. Or you cannot say I have done a flavectomy from end to end, because everybody is watching. So microscope is like a quality control for you. The whole world is seeing what you are doing. And also it is easy for us to let our juniors do, because we can watch what they are doing. So it's a very, very good teaching tool to have a microscope. But if it is not affordable, then you have to get a headlight, good headlight and a loop for all these cases. So Leela, so we went and opened, yeah, and this is like this. So as soon as you put a skin incision, you can see now it is not a small infection. Huh? This is called pan tissue grade 5 infection. So everything is involved, muscle, everything is involved. Now what do we do?
It's extensive debridement of the infected tissue. And I would like to extend instrumentation to a level above and level below.
Yeah.
Because I'm not sure of the hold of the.
So this is very, very critically important, because it is also obvious that it is unstable. So this will not heal without giving it stability. And also the patient will be in a lot of pain on moving this side, that side. They stop eating, they are not mobilizing, they become very cachetic. So it's very important that you extend nicely, clean it up very thoroughly. You have to extend your levels of instrumentation and change the screws if necessary, so that at the end of it, it should be a very clean wound as much as possible, and it should be a very stable wound, and then only you are on the first step of recovery. If you are not given that, then you are not moving towards that. So when you opened it, it was polymicrobial infection. I mean, it grew pseudomonas, and then when we sent it for multiplex, it grew so many different things. So he has first complication is polymicrobial infection. Second complication is instability. Third complication is chronic renal failure. Yeah. So that is it. So you can see that we extended the wound completely, debrided it, extended the levels of instrumentation, and this is what I call you have to do a facetectomy on both sides. So if you don't do a facetectomy, you cannot debride. So if you are putting in a cage or if you are putting in anything, that's the only other reason why I don't like to come from the side, because you don't have an access to both sides. So you can see now there is a very big gap here. You can look through, and if you look through the microscope, you can see the hole. You can see the annulus fibrosis on the anterior side. You can remove every bit nicely. Bilateral facetectomy has been done. A thorough debridement has been done, and we have extended the instrumentation. So that is it. You can see, and also if you can see, I have tried to shorten the so that the bone is coming closer to each other. And then what to do? Here is a compromised patient, terrible infection anteriorly. We don't know how much we have cleared everything. So the one good option is VAC. Yeah. So how many of you use VAC for spinal infections? Because there is a lot of controversy regarding that, but we have found that to be very, very good. Also, it gives you a lot of time to think and do what to do next. So you can see this is the first look after the VAC. It looks much, much better. So second look after the VAC, everything has become nice red and nice and this thing. And then this is also nicely consolidating. You can now see bone is now on bone, and this is the skin. Yeah. So this is a very, very, very good result in a very old patient who's immunocompromised and who has got this thing. We might have got into a problem if we have done at this stage. From here, you do a good debridement, everything, and try to close. So if you close, then again lots of problems come. So the VAC was really a good, and it came out very nice. So use of VAC, you should all, if it is a very fulminant infection, it's a very difficult infection, don't hesitate to use VAC. So another case, I mean, she is actually, this lady is the wife of a Punjab minister. So you can see that she came with a fulminant infection, and you can see that we have put a VAC, and she did not have any, see, this is the most beautiful thing. So she did not have a full closure. Can you see how the skin is contracting? It remains to be seen how beautifully it will contract by itself. No suturing that. It healed by itself. VAC. So you may not believe that this will happen, but one of the most craziest cases I have seen was when I was a house surgeon. That's what, 35 years ago. So one patient came with peritonitis, severe peritonitis, and we thought the patient is dead. So my boss, he's Dr. KSS, he was a very big legend at that time. He just put one this and another cut like this, and fully washed and all that, and on the operating table, the intestine, everything was flowing all over, because he has completely cut one, this side one, this side one. He said this is the only way this guy is going to live. Leave it open, and you have to dress morning and evening. And I was given the job of morning. It used to be terrifying, because you slowly remove the bandage, 3-4 intestines will come sticking to the bandage. You have to slowly take it off and put it and put this thing on. You won't believe, in 1.5 months, the whole thing actually closed by itself. So it is such a powerful, the skin, that's called the picture frame theory, you should read it in the pathology books will give picture frame theory, because that once you give a wound to the body, the fibroblasts take over and they will cicatrize and close the wound. So this big cut in the abdomen closed by itself without any this thing. So because when we are in house surgeon, you finish your surgical posting in 3 months and you go to medical posting. So he was so interesting. We used to go back and see sometimes what is happening. The other guy was now dressing, but he had only a smaller wound. And by the time we came to obstetric gynecology, it closed up by itself. So even this case, you see, I mean, from where we are coming, from this wound to spontaneous closure. So that's a good idea that you have to keep in terms of very bad things. You have to do it. Exposed dura was supposed to be a contraindication for VAC, no more. So even on exposed dura, we have done many times. We have put VAC, nothing happens. Only it should not be leaking dura. And the biggest contraindication is if they have some bleeding disorders. Otherwise, mostly it works very well.
What are the media that you use for revision cases? Anything specific or?
What is the?
Media. Sometimes, as you said in one of the cases, the orange was not isolated. You go for any longer durations or.
Yeah, so when you, the principles of culture sensitivity in all these cases is you must not take, in like olden days, we used to use swabs, So now swabs are not to be used. So we know that to take the pus or the tissue or the fluid in a cotton swab, it is very inimical for the germ and they get absorbed deep inside. And the superficial area doesn't have any germ. So when they inoculate it, the germs don't come. So this is the best work and contribution of the endoclinic. So the endoclinic where they are doing primary revisions of hip and knee joint. So they found the difference between swab positive germ positivity when you are using swabs and you are actually taking the tissue and putting it. Is almost double. So you should never use a swab. Second is you should inoculate it inside the operating theatre or as soon as you remove it. Now most in our medical college when I was there, you are a house surgeon. So all people will be removing culture sensitivity from morning to night in different theatres. And everybody will write it and keep it in the windowsill. There was one windowsill which was very hot, and it used to be there from morning to evening. When you finish your whole day's work, then you will change your dress and take all these together and go and give it in the pathology lab. That's finished again. So no germ will grow. And it is not enough to take pus. You have to take tissues. So because pus may or may not have the germ, but the infected tissues will have a lot of germ because that is the place where they are growing actively. And it is not enough to take it in one place. So if you go to this place, this area, so it is not enough if you just take a swab and take some all these pus and send it off. So you have to take a little bit of this tissue. You will have to take a little bit of tissue here. When you go inside, you will have to take a lot of tissue from the disc space. Then you will have to take a lot of tissue from beyond the disc space what you are curating. Like that, a minimum of 5 specimens from 5 different areas, from 5 different tissue planes taken and inoculated immediately. And you should also ask for extended cultures. Not enough to read the report at 48 hours. You have to go up to 14 days. In endoclinic, they go up to 21 days. If you are suspecting polymicrobial, then it is better that you send it for multiplex. Yeah, you can use a drain. I mean, till it leaks. Anybody? Otherwise, we go for coffee. All right, thank you.
Bar chairs ఏమైనా వేయించు సార్ బార్ చైర్ ఫర్ కంఫర్ట్ ఫర్ స్టాండింగ్.
No, 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 I am. My mind works better. My mind works better when I am standing.
Okay, sir.
పేపర్లు తీసేయలేదు. బుక్కేలు అయితే రావాలి. ఎవరన్నా అడగపోయా అమ్మాయిలు
వస్తారు చెప్పాను. అమ్మాయి సింధుగాను
ఎక్కడ మిస్ అయ్యాను? వైఎన్ఆర్ వెంకటరమణ, ఎంజే నాయుడు,
నగర్ తర్వాత ప్రెసిడెంట్. లోపల నుంచి పేపర్లు తీసారా?
welcome back to the official small inauguration, and then we are going to start the oration soon. So I request Honorable President of SSAP, Dr. Y. Nageswara Garu, to come on to the dais. Also request our past President, Dr. M. Prashant sir, to also to comment on the dais. The President-elect, Dr. V.V. Narayan Rao sir, to come on to that dais. Also request President of Vijayawada Orthopedic Society, Dr. M. J. Naidu sir, to come on to the dais. Also request our Secretary of UIS, Karlapudi Vasu Garu, and also observer from APMC to come on to the stage. And the past President of Guntur Orthopedic Association, Dr. Uma Maheswara Garu, please join us. And President of Prakasham Orthopedic Association, Dr. Malyati Naidu Garu. Sir, please join us. So, Venkatesh. So, additional DME, Dr. Venkatesh, I think, yes. Sir, please come on to the dais. Couldn't see you. Additional DME academic, Dr. Venkatesh. Also, Head of the Department of Vijayawada Siddhartha Medical College, Dr. Addepalli Srinivas Garu is around, will just join us. So request President of Association of Spine Surgeons of India, Professor S.K. Sivachava sir, please come on to the dais. And our guest of honor and orator for this year. It's our great privilege to have you here, sir. I request Professor S. Rajshekharan sir, Ganga Hospital, Coimbatore, the man of the day. So please come on to the dais. Okay. So please come on to the short picture. Well, a small lamp lighting ceremony before going on. Shall we have a lamp lighting? I request Professor Rajshekharan sir and Professor C.K. Srivastava sir to light the lamp. Thank you, sir. So I request our Honorable President, Professor Y. Nageswara Garu, to give the welcome address.
So, good morning, everybody. And on behalf of the Association of Spine Society, I welcome you all to this day of a wonderful conference. And for the last 3 years, we have been conducting regularly on the same issue of the spine. And we are calling our masters of the spine surgery, Dr. Rajshekaran, and many stalwarts from the rest of the India. And then the topics themselves is not only for the specialists of spine surgeons, but also for the learners, postgraduates, and general orthopedic surgeons. They are always useful. Right from the last 3 years, we are following them, and they are wonderful and enlightening everybody at each level. And the faculty themselves, headed by the spine doyen, Dr. Rajshekaran, is never tired of teaching all of us, even if it's a postgraduate or a super specialist or a general spine surgery. Thank you, sir. Thank you very much. And I wish this conference a very grand success.
Thank you, sir. Now I request the President of Vijayawada Orthopedic Society, Dr. M. J. Naidu, sir, to speak 2 words.
Good morning, everyone. Respected dignitaries on the dais, distinguished faculty, dear colleagues, postgraduates, and friends. It is my great honor and a privilege to welcome you all to this historic occasion, the 8th annual conference of the Spine Society of Andhra Pradesh and the inaugural meeting of the Amaravati Spine Club. We are truly privileged to have with us the stalwarts in the field of spine surgery, led by Professor S. Rajshekaran, our course director, whose contribution to spine research and clinical practice are an inspiration to all of us. I also extend a warm welcome to Professor S. K. Srivastava, President of Association of Spine Surgeons of India, who will deliver the prestigious Spine Society of Andhra Pradesh Varation 2025. Your presence enriches this gathering immensely. The launch of the Amaravati Spine Club today marks another milestone, learning and innovation. I appreciate tireless efforts, vision and dedication of Dr. Naresh, organizing excellent academic program. On the behalf of Vijayawada Orthopedic Society, I thank the organizers, faculty, and delegates for making this event possible. Thank you very much.
Thank you. Thank you, sir. I request Dr. Vasu Karlapudigar, Secretary of UOS and also APMC Observer for this meeting.
Good afternoon, everyone, and a warm welcome to Vijayawada from our Vijayawada Orthopedic Society and respected dignitaries on the dais, especially Dr. Rajshekaran sir. So, just I want to say a few words. Since my postgraduate days, I am listening to sir's lectures and classes. So all the PGs who are there, really you are very lucky to be associated with him for today's meeting. And even the practitioners, like I see many of the practitioners. So all the time, like whenever we listen to sir's class, that's why I'm discussing the other previous moments. Every time we learn some 4 to 5 new points from him, and it is very useful in our practice. So nice that you all were there here, and it's a very huge crowd, and we thought of having many more previously when we are discussing with Naresh, but because of the time and space constraint, we couldn't allow many of you. So thank you, sir, for being with us. And one more thing is like the Amaravati Spine Club, I think it should give a remarkable change to this part of the region. And I thank Naresh for giving such an opportunity to be here. Thank you, Naresh, and thank you one and all. And wishing all the success for today's CME. Thank you, sir.
Thank you, sir. Thank you very much, sir. I request Professor Umamaheswara Garu from Guntur Orthopedic Association to say a few words.
Good afternoon, everybody. Welcome to the 8th Spine Society of Andhra Pradesh academic meeting. This is being successfully done for the last 8 years. This is only one-man show, Dr. Naresh. I am really proud of Dr. Naresh because he's from Guntur, who made our Guntur in the world map outstanding. So let us give a big hand for the Naresh for successful conduction of this meeting. So have a nice academic feast because we have a great teacher, Rajshekaran. So I wish all to have a nice academic feast. Thank you all.
Thank you, sir. Request Professor M. Prasant, sir, past president of SSAP, to say a few words.
Good afternoon, everybody. Firstly, I would like to say my gratitude and thanks to our Professor Dr. Rajshekaran. We are very fortunate to have in his good efforts and in his good looks. It may be because of Dr. Naresh, because he is one of the most favorite disciples of Dr. Rajshekaran. So our subspecialty in our state is fortunate to have, especially Dr. Naresh, who is showing utmost importance and is getting, as we are all aware of his skills and talents, and recently he was awarded internationally. So it is prestigious award received by our friend, our colleague, and the secretary of our association. And I would like to say thanks to our other faculty members of the Spine Society, Srivasav and others. I extremely feel happy and proud to be one of the past presidents because it is slowly growing in its strength because of our most talented and skillful personalities of this specialty. And if you take, for example, initially there were very few delegates and the persons who are interested in this subspecialty. Now, if you take, there are a number of persons after their completion of post-graduation are willing to join in this subspecialty. It is just because of Naresh and others. So I would like to see this as a huge subspecialty in our state. For that, I always look for the best of the best things in this subspecialty. And if you take, for example, the diseases and the emergencies in this specialty are growing because of the high velocity injuries or the diseases. So it needs the specialists for the treatment of our people in our state. So I wish all the persons who are showing their efforts in this particular subspecialty all the best in future. And definitely I am sure it's going to be one of the prestigious subspecialty in our state. Thank you very much for giving this opportunity.
Thank you, sir. Thank you very much. And now I request Dr. Malyadi Naidu Garu from Prakasham Orthopedic Association, President of Prakasham Orthopedic Association. A few words.
Good afternoon to everyone here, and respected dignitaries on the dais and half the dais. And I thank the faculty for inviting me onto the dais because we are working in a small places. And I was the first person to operate spine surgeon in Prakasham district in 1993. So basically, I'm a trauma surgeon, but I do have some interest in the spine. And especially when professor like Rajshekaran comes, I never miss. His lectures I never miss. And every Ganga courses I used to attend. Thank you one and all for inviting me. Thank you, sir.
Thank you, sir. Thank you very much. Now I request our President-elect Narayan Rao sir to speak a few words.
Incoming voice call from Heart Digitals.
Good afternoon, dignitaries for the dais.
First of all, I thank you all for electing me as
Incoming voice call from
President of
Heart
Spine
Digitals.
Society of Andhra Pradesh. I am attending almost
Incoming voice
every
call from Heart
state's
Digitals.
spine conference. I will call
Incoming
Dr.
voice call
Rajshekharan
from Heart
Garu as
Digital.
Jagat Guru. He is the one who make us to learn so many things. Thank you very much, sir. Thank you. And I wish all the best. Thank you, sir.
Thank you very much. I request our additional DME academic Dr. Venkatesh sir to say a few words.
Good afternoon to all the dignitaries on the dais, especially Dr. Rajshekharan sir and Srivastav sir, and also my colleagues, seniors and juniors, and postgraduate students. So, this is an academic feast today, especially very, very useful for postgraduate students. So, be cautious and learn at least 2 or 3 points thoroughly daily, so that in your entire 3 years course, you can able to pick up so many things and you can master in so many techniques. So whatever the seniority and experiences they share with us, they are very, very golden words, and keep it in mind and do in future very well. And I thank Naresh for calling me for this academic feast event. Thanks a lot. Best of luck to everybody.
Thank you, sir. And Dr. Addepelli Srinivas sir, head of the department of Siddhartha Medical College, Ortho Department.
I congratulate Naresh for getting the resource person of nationally, internationally, Dr. S. Rajshekharan sir, for guest lectures every year. And we are very much thankful to you, sir, for giving us very good inputs and enlighten ourselves and all the youngsters. Thank you, sir.
Thank you, sir. Thank you very much. Now I request our guest of honor, President of Association of Spine Surgeons of India, Dr. Professor S. Sudhir Kumar Srivastava, sir.
A very good afternoon to all of you. I am quite thankful to Dr. Naresh Kumar and the Spine Society of Andhra Pradesh for giving the opportunity. Actually, I feel lucky to be here today. When Dr. Naresh Kumar called me about this, so it was 100% yes, I told him, because the where Professor Rajshekharan is there, you will always learn something. I am still a student, I also learned few points, and I think that should be the habit of each and every student. He should remain a student throughout life. Then only your growth is going to happen, and this course is no other than that. So, and you see the enthusiasm in Professor Rajshekharan.
Incoming voice
He has
call
done
from Heart
enough
Digital.
nationally, internationally, everywhere. Still, he is in the path of progress.
Incoming voice call
And
from
I
Heart
think
Digital.
he is a role model for this, and there is no doubt about this.
Incoming voice call from Heart Digital.
I am really lucky to have arrived here, and he has given me the opportunity to interact with you. I wish great success in this whole academic feast, and I was quite happy to listen. Since last 8 years, Rajshekharan sir is coming every year. I think that should be the attitude of each and every teacher. Wherever he is getting opportunity to teach, he must teach. Thank you very much for this opportunity. Thanks a lot.
Thank you, sir. Thank you very much, sir. It's an honor to have you for our annual meeting, sir. Now I request our beloved Dr. S. Rajshekharan sir to say a few words on 8th times for our session.
So thank you very much. I think I have spoken enough from morning, but just to mention that the biggest problem India is going to face in another 5 to 6 years is a large number of doctors who are not trained properly. So the reason is that we are having around 3,000 orthopedic surgeons coming out every year, and government has given a policy that it wants to double it in the next 3 years. So within 3 years, there are going to be 6,000 orthopedic surgeons coming out every year. That means the total number of orthopedic surgeons now is 40,000, but every 10 years we are going to have 60,000 people coming more. But in many of the places there is no good provision for full training. Naturally, when you expand very fast, your infrastructure cannot be very good. So there is a very important need for meetings like this, and I should congratulate every one of the persons who was on this dais, because I know maybe Naresh did a lot, but he couldn't have done without the blessings and guidance and permission of every one of them. So a big thank you to all of you on the dais, and I'm sure that meetings like this go a long way. So for me, it's a ritual to come to SSAP every year. So I'm not sure whether you enjoy it or not, but I enjoy it quite a lot because it's a very different format. It's a good interactive session, and I'm sure that this will happen every year. Thank you very much for the opportunity. Thank you.
Thank you, sir. Thank you very much, sir.
I should also say thanks to our president of the ASSI, Dr. Srivatsava, for being here. It's a big honor to have him here.
Thank you, sir. Thank you very much, sir. Thank you all for. Yeah. Thank you, sir. Thank you, Alfred, sir. I request Professor Srivatsava, sir, and Rajshekhar, sir, to stay back for the unveiling of Amaravati. Yeah? Edi? Yeah, stay there. So you stay here, sir. Yes. Yeah. So this Amaravati Spine Club has been, we had just had a thought of having it here. So there were so many number of spine surgeons every year, and there are a lot of opportunities now compared to when we were students to get trained under spine. And now we have good enough number of surgeons who are dedicatingly practicing spine surgeon in and around Guntur. So this concept of Amaravati Spine Club has started so to have our own society in this area. So predominantly surgeons from Guntur, Vijayawada, and all the near and dear cities will be a part of Amaravati Spine Club. And we are anticipating to have more programs like this. So I request Professor Rajshekhar sir to unveil the logo of Amaravati Spine Club in presence of ASSI President Dr. S.K. Srivatsava sir. So you need to press the presentation button. So, this one. So I also request all the. I'll request all the spine surgeons of this area, please come on to the dais. From Guntur and Vijayawada and Ongole, everybody please join. So just the screen be visible there. So good number of exclusive spine surgeons in this. Srivatsava sir, please. Yeah.
Ladies and gentlemen, may I have your attention, please? The show starts in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, go.
So the logo here depicts the iconic towers of our future capital, Amaravati, and then the stupa of Buddhist stupa design. incorporate inside the vertebral body. So I request Professor Sudhir Kumar Srivastav sir to say a few words about launching of our new spine club, followed by Rajshekhar sir. First Rajshekhar sir will speak, then followed by
So a big congratulations to the whole fraternity here. I was really surprised to see so many dedicated spine surgeons. This is a really fantastic trend which we need, because the number of people who are going to require spine surgery and spine care, not necessarily surgery, but spine care is going to be very huge. And big congratulations to you. Every society starts with some ideals. And it first starts as a social society where everybody gets to meet everybody, and then it should quickly move on to an academic society, and then it should also move into a research society. So although academics and research are also very important, it is very important for all of you to meet often, because the comradeship which you develop is so important. Then every spine surgeon to each other is not a competitor, but is a colleague and a friend. And that atmosphere is very important in your professional field. So in Coimbatore, when we started the Coimbatore Orthopedic Society some 25 years ago, at the time there were 60 orthopedic surgeons in Coimbatore. Now there are 520 orthopedic surgeons. But what happens is, otherwise you don't know each other. And sometimes when patients come to you, you may pass a comment, or you may, when you don't know who's the other person, many things are possible. But when you know them face to face and you have moved with them as a family, then nobody talks ill about anybody in Coimbatore, because everybody is a colleague and everybody is a friend, and it creates a very nice atmosphere to practice. It's a real pleasure to practice. So I think you should all be friends first, colleagues first, comrades first, and then surgeons next. And after that, you should become academician and researchers. I'm sure that under the able leadership of everybody over here, this will definitely happen. So congratulations to all of you.
Thank you, sir.
I am extremely happy to see all the young grade brigadier. And I think what Professor Rajsekaran told, this is the foundation of any spine club, I'm telling you. And what happens, it is not only the pleasure. Sometimes you have difficult time during your practice. And these, friendship, it does work. Now seeing the medical legal scenario in our country, now if you have opinion of a, senior surgeon who is senior to you, or your colleague, that makes a lot of difference. You don't hesitate in asking any opinion. Always it is better. I have seen many of my seniors to sending the patient for second opinion. They tell us very clearly, I have done this is my field, you can also take second opinion. So this makes a thing very good. And in fact, many a time when you are in problem, you have complications, the opinion of other friend might help you. Sometimes if it is a very, major case where a lot of complication chances are there, you can call your one of the colleague. You are working under the effect of adrenaline. Okay? So your colleague can suggest on table, it is better to do it this way. I think we are leaving this. I think that should also be done. It will always useful. And as Professor Rajsekaran, spoke, that, repeated meeting with each other, having monthly, meeting, clinical meeting, will also add to your academic value. And all these things are quite possible. And I am sure with Dr. Naresh around, he is going to develop this culture. You must enjoy this culture. And this is going to be very fruitful. We also, in Bombay, we started Bombay Spine Club. And it became like a conference now. So it is a society now. The same thing, same ladder, you are also going to, go up and up. And I think even the sky is not the limit. Thank you. Thank you very much.
Thank you, sir.
So congratulations to all the young team and led by Dr. Naresh. I used to call Naresh as a miracle kid. Whatever he takes up, it's going to be a great hit. We observed that during our association for the 3 years, during our tenure at WhatsApp, our association, the Orthopedic Surgeons Association. So I wish all of you a great good luck and then great success. It will definitely going to be a grand success.
Thank you, sir. It's a really, it's a memorable moment. When we wanted to start Spine Society of Andhra Pradesh 10 years back, we were actually really thinking, is it right time? So why do we need a society? Now we have reached a stage where we can have Amravati Spine Society, and there is a North Andhra Orthopedic, North Andhra Spine Society is also forming. So yeah, it's already formed. So thank you, sir. Thank you all for gracing the occasion. We just have a group picture with sir, and then we'll start the next proceedings. I also request President-elect Dr. Narayan Rao sir to join the picture. Thank you. Thank you, sir. Yes. Yeah. Get that. Anything is okay. So we have reached next agenda in our program is to have a Professor S. Rajshekaran SSAP oration. So this we have started 3 years back. This is going to be our third oration of Spine Society of Andhra Pradesh, which we named it as SSAP Professor S. Rajshekaran oration. So it's our customary whenever we start a oration to know about sir. I think there are a lot of new postgraduates here. And also, it's like, what do you call Vishnu Sahas now? Any number of times you listen to it, you will get more inspired of what stature of our sir. Professor S. Rajshekaran is chairman of Department of Orthopedics and Trauma Spine Surgery at Ganga Hospital, Coimbatore, the largest orthopedic specialty hospital in South Asia with 650 beds and 35 operating theaters. 20,000 is an old figure. I think it's changed now to 30,000 major surgeries per year and 50,000 new patients, and total outpatient attendance is 150,000 per year. Those are remarkable, mind-boggling figures. Nobody can even imagine to have individuals set up this kind of a infrastructure in India, which we are all proud of. And sir has done MS Orthopedics from Madras Medical College, Chennai, and FRCS in Royal College of Surgeons, Edinburgh, and also FRCS London, and MCH University of Liverpool, and PhD from Tamil Nadu MGR Medical University in 2000. So here almost had all the leadership positions which you could any orthopedic surgeon or spine surgeon could dream of. Sir has been president of Asia Pacific Spine Society, it's still acting president, and chair of Evo Spine International Board, and past chair of Evo Spine International Research Commission, and president of CCOT, and also president of Cervical Spine Research Society Asia Pacific. He had been served as the president of Indian Orthopedic Association and president of Association of Spine Surgeons of India for 4 years, and president of International Society of Study of Lumbar Spine, and president of World Orthopedic Association Concern. There are other distinct academic distinctions which we are all proud of. Sir has received Hunterian Professorship the year 2011 to 2012 by Royal College of Surgeons of England, which is extraordinary honor for Indian surgeon to be honored with Hunterian Professorship, and distinguished visitor of Harvard Medical International Boston, and Grand Rounds lecturer of Dartmouth University, and adjunct professor of orthopedic surgery in Tamil Nadu MGR University, and past member of faculty of medicine Annamalai University. These are the leadership positions which I just spoke about, and has been examiner for National Board of Examinations, New Delhi, and D.Y. Patil Deemed University, Pune, and National University of Malaysia, Kuala Lumpur, and PhD examiner for the Faculty of Sciences of University of Pretoria, South Africa. And as leadership positions of Journal, Deputy Editor of Bone and Joint Surgery, Deputy Editor Journal of Spine, Deputy Editor of Global Spine Journal, and Deputy Editor of Spine, and past Deputy Editor of European Spine Journal. And significant international research awards, this is what inspires us for a lot. So you don't get a time to actually go through these things. Sir has received North American Spine Society Outstanding Research Award. So this is an extraordinary award any spine surgeons in the world they dream of. But Sir has received this award for 2019, 2020, 2021 and 2022. So it is a remarkable achievement for receiving this award. And Easel Spire for Best Spine Research for past 6 years. So to 2004, 2010, 2013, 2017, 23, and recently this year also they won Easel's prize. This is remarkable. And also Easel's Lifetime Achievement Sir has received in 2025, and Easel's Best Paper Award in Basic Science in 21, Easel's Best Paper Award Clinical Sciences also, and Asia Pacific Orthopedic Association Best Presentation Award in Infection category, and CCOT Research Award, Asia Pacific Spine Society Best Clinical Research Award, Asia Pacific Journal Award for Best Clinical Paper Published, and Asia Pacific Spine Society Best Basic Science Research. So all the awards whichever anybody created, Sir is there to win all those international awards. And Eurospine Open Paper Award 2005, and Sofa Meridonak Best Paper Award for the years 96, 2002 and 2006. This is illustrious career of Sir, and also many national awards. Harivom Olympic Research Award, and BC Roy Award, and Harivom Research Award for in 2004 again, and Harivom Ashram Pretit and Rangachari Research Endowment Lecture Award at Bhubaneswar, and Tridential Award for the teachers in 2012, and Scroll of Honor again from the Teachers Day from Tamil Nadu MGR University, and Scientist Award also from the Tamil Nadu government, and ASSI Publication Awards continuously from 2003 to 2022. So all the awards till now, I think 22 is a world picture, and then Sir has won the research award. Once there was a meeting, people were asking, Sir, when are you going to stop so that we can compete? Sir has boldly said, I am not going to stop. If you want, you can try, sir. So it has become for ASSI to create a great like winner and runner also. So because somebody wants to have that inspiration to be done. And publications, this is something which we are all proud of. 490 publications in international journals, and 103 publications in national journals, and 85 book chapters, and 619 international awards, and 617 national presentations. That is the illustrious. So it looks very simple when Sir stands here and talks. We don't know about his stature when he talks in an international forum. We are all very blessed. So he had a special affection and love for SSAP. Every time we call, actually this time Sir has reminded me, Naresh, what happened this time you are not asking about. So I just miscalculated that we had a Sir in Vizag. So I thought we had the meeting in January. So Sir is very particular to get it back. Thank you very much, sir. And it's also our privilege to have a oration on his name. And we are extremely fortunate that this year's orator is Professor S.K. Srivatsava, sir. So I'll just The first oration has been given by Sir himself 2 years back, and the second oration is given by Dr. Abhay Nene. This is the third oration which we are having, Spine Society SSAP Professor S. Rajshekaran Award, Oration Award. So this is, we are also go through the illustrious travel by Professor Sudhir Kumar Srivatsava, sir, who is BSc and MBBS and MS Orthopedics and Spine Fellowship from Switzerland and Germany and UK. So current positions, sir is now working as a professor in orthopedics at KJ Soumya Medical College and Research Center in Mumbai, and consultant spine surgeon at Dr. L.H. Hiranandani Hospital in Mumbai, and is now the president of Association of Spine Surgeons of India, and is going to have it for next year also in the team. And in his past, sir has worked as a professor and head of the department of orthopedics at Seth GS Medical College, KEM Hospital, Mumbai, and past president of Bombay Spine Society. And sir is appointed as junior faculty in Department of Orthopedics in 1992 at KEM Hospital, Mumbai. And then soon he became a very active member in Bombay Spine Club and had an opportunity to work with Professor Dr. Vijay Lahiri, whom we are all very proud of for his innovations in pedicle screw fixation and also craniocervical junction pathologies. In 1996, was promoted to associate professor and unit head. And after becoming associate professor, he started doing short-term spine fellowships at different centers in the country. This is with in St. Gallen at Professor Jasinski, and in Kilsabad with Professor Holmes, he has done a fellowship. And this is Professor Casper at Hamburg, he has done a fellowship in microsurgery. And with Werner Recurrent Clinic in Germany. And these are all the short fellowships which Sir has been continuously doing and educating and refining himself. Those were the days where we had to travel abroad and get the knowledge. Sir has been always a good seeker of knowledge, and biomechanical lab at University of Ulm, and EVO Spine Advanced Spine Fellowship at London with Mr. John Dowd, and took over as a professor and head of the Department of Orthopedics in January 2015. And continued his teaching and visiting fellows, and retired as a professor of head of the Department of Orthopedics in May 2021, and he now joined KJ Soumya Medical College and Research Center, and after retirement from KM. His contributions, he has been a senior medical faculty across Indian medical universities, and National Medical Commission Inspector, and examiner of undergraduate, postgraduate and super specialty courses. He has the distinctions of medals during undergraduates and postgraduates, and he won VTI gold medal. VT Ingalhalikar gold medal is a very prestigious gold medal of Association of Spine Surgeons of India for his work on irreducible atlantoaxial dislocations and vertebral column dissections. And he has received a Lifetime Achievement Awards by Spinal Cord Society of Delhi and Delhi Spine Society. He has research interests in atlantoaxial dislocations and rigid spinal deformity corrections and reconstruction of spinal column, and has many publications and authored book chapters and 80 publications in national and international journals. So it's our great privilege to welcome Professor S.K. Srivatsava sir for his oration. We will request Professor Srivatsava sir to come on to the dais. Somebody get that. So another thing. Request Professor S. Rajshekaran sir to present the medallion. Meanwhile, we'll connect the laptop. So they'll attach, sir. Keep the black drop also. It's connected. I request Professor Rajshekaran sir to honor orator of 2025 SSAP Rajshekaran Oration Award.
this leave?
Yeah, not learn more. Later, just keep it side.
Yeah, side, yeah. I can go there, yeah. Yeah. Thanks, Dr. Naresh, for your kind words. And I'm quite moved and thankful to the Spine Society of Andhra Pradesh that you have given this golden opportunity to me, and that too in front of Professor Rajsekharan. I have a tremendous respect for Professor Rajsekharan, and you know, the words are actually not there how to express that. We have been growing, seeing him as a mentor, as a teacher, as an inspirer. So he has inspired millions, I would say, throughout the globe. And I think the best part is still he is continuing. And with him, I have learned that a doctor cannot retire unless God retires you. And this is quite practical in many of the senior teachers we have been seeing and observing. Now, lovingly we call him Raja. And it is not only in India, abroad also he is called Raja, and the literal meaning of Raja is king. He is a true king of knowledge, innovation, research, and vision. He is a visionary. And Dr. Naresh has already, shown all his achievements, which is countless. You start counting, you have to have days in that. Ever smiling, he radiates confidence and determination. And that's what the junior, they get, really impressed with what confidence he has. He is a mentor par excellence. Wherever you have an opportunity to work with him, even for a month or few days, it is always utilize that. This testimony of his hard work and determination is actually practical. It is visible from outside, what he has created along with his team for education, research, innovation. He is always ahead of his time. And what is most important, giving back to the society, which he is doing every facet of his life. And I had a great opportunity to invite him for our Platinum Jubilee Conclave. So KM Hospital was Department of Ortho was completing his 75 years, and we were quite lucky to have him with us. And what was the talk of his oration was the progress in academics and research for whose benefited. So whose benefit, this was the question, and he actually spoke very well on that. And this was the day when you see on that side where he's looking, all 5 stalwart and giants of orthopedics are sitting. Dr. Sancheti is there, Dr. Lad, Dr. Chaubal. Chaubal was that time was the teachers of teachers, and Dr. Alan Vora, you might have heard his name, excellent teacher. And his talk was so much impressive that many people after his talk told the best choice you had in your Platinum Jubilee oration. And that was a wonderful and fruitful day. I had opportunity to call him, and I am very thankful today also that he accepted that and we did it. He's a visionary. He senses the current need and always thinks ahead of the time. So though he's an achiever or orator, but he is an iceberg. Don't just go by his academic achievement. He's a thinker, he's a spiritual analyst, he's an intriguer, why it is something and something not. And that is very important. Always you have question in your mind. So his subconscious mind is working in a different facets of life. And that is very, very remarkable. So I wish that may the Almighty bless him with all the happiness of his life, sir. So we are really thankful to you. Now, the topic of my oration is conventional tools in a high-tech era. Is it still relevant? We fully admit that growth of science and research should be encouraged. Development of newer equipment implants should continue. There is appreciable development in metallurgy, imaging, and biologics, so newer tools are essential. But you have to test its merit and demerit. Usefulness in a given scenario should always be evaluated. Do conventional instrument implant and previously practiced management strategy have no role in this era of advanced technology? Certainly not. They do have roles today and probably in coming future too. And this is very, very important for coming generation. There are few equipments which we were using earlier. Suddenly you have a case, and if you ask in theater, the theater nurse doesn't know it. She has never seen it, and forget about the newly appointed postgraduates. But that should not be vanishing from your theater. I will be showing you few examples. Now, this we used to use during high-grade listhesis. This is the Harrington rod, okay? So suppose L5 has gone quite deep inside, it is sunk. It will be difficult for you to pass the pedicular screw. So centrally you can put it and you can distract it, then that vertebra got pulled up, and then you can pass easily. So these were the small things which were always used to have in our spine set. Now this simple looking stainless steel wire, this can be molded in any form, whatever you want, and it can be used as a sublaminar wire. Nowadays, we have this, finer implants. We have rod, screws, hooks and all. But still you can use the principle which you used to do earlier with the Harrington hook. Now this is a case of congenital scoliosis, where I have excised the hemivertebra, which was mainly the posterior part it was, and it was fully excised. I never compress on that pedicular screw, but if you very hardly you compress that screw becomes loose. So in that case, it is better to use hooks up and down and compress it, and later on you put the rod. Now here, the pediatric spine and osteoporotic spine, the sublaminar wire and hard steel fixation is quite good, because in TB and the posterior element is almost normal. So there the cutout will be very less, and the chances of collapse, and it is you are putting on the tensile surface. And all these things which I am going to talk, I would prove practically and scientifically. Apart from playing crucial roles, sometimes they bail you out in difficult situations. Now is a 35 years old male daily wager worker, only breadwinner of the family, and he had paraplegia with bladder bone involved. If you see this column, it has everything. It has translation, angulations, and there is a circumferential compression. So we put this implant. So what are the advantages of this? It does segmental correction. It does nicely the column alignment, and you can do later anterior reconstruction. Now you have to learn this technique how to do. If you suppose you tighten the wire on one side only, the whole of the heart seal will be shifted of that side. So learn how to do that, and this is going to be very, very useful. You see, the cost of this implant is total is 1,980. Heart seal reckoning cost is 900, and each wire it causes, if you count that 90 rupees, and total is 1080. So total cost of implant purchase is just 1,980. In actually Maharashtra, Bombay, KEM hospital, this implant patient had to purchase. Okay, rest of the thing were free. There are no surgical costs, no bed charges, but implant patient used to purchase. So our policy should be that in that setup, how could you help more and more number of patients? Slum dweller, complete paraplegia, he recovered completely, segmental and sequential correction of deformity with sublaminar wire and heart seal rectangle. Now scientifically you see, the implant has been put on the tensile surface. It is not going to fade. Posterior element is intact and healthier in TB spine. It is not a rigid implant. There is a micro movement, and this micro movement in axial direction, it enhances healing. Anterior body is struck better for inflamed and osteoporotic bed. So see here I have pushed the anterior bone graft, and So ground reality of mass population, affordability and prevailing situation. Now this is published in 23. Implementation of advanced care planning will depend on civil society and the palliative care sector until government support is available. Now they cannot travel into today's health tourism vehicle or cutting edge technology bearing 5-star hospitals. Thanks to our past mentors and mentees in health who remain grounded to the realities and treated these patients efficiently without compromising the outcome. Now, actually, this question was once asked to me in a conference, and that's why I thought it is better to include in this talk. When you have a Rolls-Royce car, then why do you wish to travel in a bullock cart? And see the situation. It is situational, okay? Na? Now, see, this cart is relevant for the roads in a village during rainy season. And this side, this car is irrelevant for the roads in a village during rainy season. So we have to understand our society, our availability of the thing, and the status of the pocket of our patients. Now, again, young boy, deformity and deficit. So I usually use this versatile approach. So you actually reduce one-step surgery, same incision, you go posteriorly, anteriorly, and do the full job. And this we published also. So from behind you go, open the chest, and also come down. And same rib I use for anterior strut graft, which I have found that it never fails unless you have just kept it loose. This doesn't fail at all. It heals properly. It's totally recovered, and you can see the rib graft, strut rib graft. So in government hospital, poor box fund is limited. You are a policy maker, so your policy is such that you are able to use that money for maximum number of patients, but without compromising the outcome. So if X amount you exhaust among 3 patients or 30 patients, this is a policy decision. And being an HOD, I never stopped anyone to use. But in my unit, it was definitely a rule that don't spend anything extra. If I am there, I am going to use this, and I can guarantee you that you are going to be all right. And this has happened. And that's why I am speaking here so confidently. So utilizing among 30% is more judicious and rational. Moreover, without compromising on long-term clinical outcome with scientific background and understanding. This I have also presented in Germany when I had gone there. Sublaminar valve, they just jumped. There are chances of deficit and all. But see, now the SRS quote is that the incidence of complication by sublaminar valve is 0.6%. And if you learn this technique, this is going to really help you in your future whenever you are stuck in some situation. Again, child with paraplegia requiring fixation extending to the lumbar region because it is affected. A single rod can be molded and used as hybrid system. So what I did, this is a titanium rod which I bent in a U shape. So dorsal side pediatric bone, passing the screw, and that screw should be available. That young, patient, you should have a separate system. Otherwise, the tulip of the screw becomes so prominent that you are able to palpate those screws later on. So just bent it U-shape. Distally I have passed the pedicular screw and just bent. Those 2 arms are fixed with that. Okay, and that was the picture. So use the hybrid fixation in such situation. Another girl, paraplegia with bladder ball involvement for more than 1 year, 5 years only age, and you can imagine her quality of the bone. Okay, only 12 kg D4 to do 11 calls on a KT. Now, here again, same thing, fully corrected. I utilized fibula. I harvested fibula and jam-packed that, did not move. And we actually published such small kids, recovery of long-standing neurological deficit in pediatric dorsal spinal, a single center experience of 13 cases. And now we don't believe that if there is a 1 year deficit patient will not. See, this patient walked, okay? Walked happily. Now, you should know the technique. Suppose you are using rib graft and just drop a single rib piece there, this is not going to unite. Never it is going to unite. So we always try to put whole width. So what I have done, I have cut in 3 pieces. I have tied the 2 pieces which is put anteriorly and one little longer piece which is placed posteriorly. And you can add a small chips graft anteriorly as an onlay graft. Okay? So this we published in ACL journal. Outcome analysis of anterior reconstruction with rib graft and tuberculosis of thoracic spine. If you put cage here, the sharp edge of the cage might sink in inflamed or osteoporotic bone. So usually it sinks and then you start everything is failing in follow-up. Now this is another patient. Again, this the patient I was referring to. I will show you his story. He was paraplegic with hemiperitoneum and pneumothorax. He was admitted towards surgery site, abrasion of the back at the fracture site, and he was admitted. Then when he came out of all those problems, then he was asked to take over and do the things if required. 3 weeks old injury, grade 0 lower limb with bladder ball involvement. He had back pain, difficulty in turning and then attempting of sitting, at any attempt of sitting. Either you accept the malalignment and mobilize with brace or attempt to realign and fix, and that will require release, a good release. You can see in MRI picture, 2 bodies are at the same place. Same level, there are 2 bodies because there is a significant overlap, okay? And they are not in connection. So you notice the malalignment of midline. K-wire at the site of pedicular screw. So you can see it is column is totally displaced. So as soon I got this case, I inquired to the in-charge sister of the OT, do you have Harrington outrigger? She just asked me, what is this? But she had not seen the Harrington outrigger. But Uma Surgical had this. I think you might have heard name of. His father, the son is at present the MD of that, father is still there. So he told, yes, we will arrange it there in my godown. So I asked for that. And see, after doing that, just put the hook proximally and distally, and after doing a good release, means I could see that it is moving, and then gently distract and align it. And it got aligned very nicely. You can see this is the picture, it is aligned. So sometimes these old instruments, they work wonderfully, and it will really help you. Okay, so all my listhesis cases, high-grade listhesis, I used to use the midline Harrington rod. And before putting the screw in L5, I used to just distract, that used to come up, and then I used to easily pass that. High-grade spondylolisthesis. Listhetic vertebra is deep-seated. Use of midline Harrington rod temporarily to make sunk pedicle more accessible, and you can easily pass. Nowadays, we do with the reduction screw. Now, what is the problem with this? When you distract on the screw, sometimes screw becomes loose. And many times I have seen abroad also. Many of the surgeons, they used to change the screw and put the wider diameter screw. And this was a very common practice to use in Werner Wicker Clinic in Germany, where Professor Jilke used to work. They used to distract it. And this I am talking about 1999. Congenital scoliosis. Here again, if you see, there is deformity. One side it is fused. You can see this posterior element, it is not full. Okay, the left side it is fused. Right side there is a small vertebra where there is a posterior element is almost as isolated one. So I exercise that again here. I compress this on proximal and distal hook and then tightened the rod on the screw. So I took use of this hook, compress it so that index screw will not become loose. You have just taken the help of, and this is a pediatric spine. You cannot fix so many levels. So always compress on the hook and then put the screw there, and you get a good correction also. Now this robot. Now, if you see, the several years have demonstrated contrasting results. Several papers which has been published all these years. The accuracy of robotic assisted pedicle screw placement has not been found to be consistently high. Rangel et al. Found the approach demonstrated lower accuracy. But see, these paper would vary. The institute which is going to use that, they are going to talk nice thing about that. But it is your practical judgment. Today what I feel, if you have a facility, and sometimes you can even refer the cases, when you have a congenital issues in that particular vertebra. In that case, it is such a deformed vertebra that your freehand technique might injure the patient rather. In that case, it is quite acceptable. So you will be finding all these people, papers, but what is more important, that you make your own assessment. Okay, this CT is showing this, it is better to have, like a navigation. Navigation is a robot everybody cannot afford, or not all the institute cannot also afford. They don't want to put that much money. So you should have navigation. Navigation is the thing which is essential in those cases. But you cannot blindly reject navigation because it has a definite role. So it should be considered in anomalous pedicle. Okay. Sometime you have these older implant as a bailout thing in difficult situation. Now this, again, this girl was sent to me already backed out implant 11 years. So those pedicle are also fired. So again, same thing, I converted it, hybrid fixation with reconstruction, and she became okay. Now this is backed out implant again with occipital. So now you can see here, a plate has come out, and this is the situation. He has started developing deficit again. This is intra-op, you can see. So this was my planning. So what I thought, those two holes which are there in the center and the side, I will pass wire. And we did that. Simple implant, okay, and you see this is the intra-op. So I just passed the wire from that. Earlier we used to have occipito-cervical fixation. We had a lot of cases of AAD. So we had this wire. So we knew how to contour the wire. Contouring of the wire is extremely more. Otherwise you will struggle in occiput. You contour in such a way, you just insert it, you have given the shape such, and just bend it on this side, and just if you turn this open edge, it starts popping out. And there sometimes you can use a very small hook and just hold that, and again gently you pull it out. It comes easily. And see, in this case, again the same plate was put on that, and we did fusion nicely, and he has recovered. And it is nicely now fixed and fused. Now, previously practiced management strategy. Actually, we don't have much time. Otherwise, I would have talked about, about this physiotherapy, about the traction. All these things are very important. I think all postgraduate, they are not exposed at today's era. They are not exposed to this. And I think that is also, previously practiced management is give instability and inflammation time to heal. Okay. Now this instability, which is a temporary phase of natural history of that pathology, give time to heal. Don't be suddenly next day you do the thing. Surgeon and patient both should have patience. This is extremely important. Treating the patients conservatively is more demanding. It requires essential close observation, follow-up, and regular communication with the patient. Now, as Professor Rajsekharan was telling about the surgery, many a times you strongly feel that there is not much a problem. Why he is asking every time surgery? If you have a very open discussion, someone has put in his mind so emphatically that if you don't get operated, you will become paraplegic. If not today, maybe a month later. So first you take out that feeling, you explain him, spend time to know this is not going to happen. If this is going to happen, we are working here, you can come anytime. Okay? So once you take out that fear with almost half an hour of mainly the older age group lady, and they become so happy, I'm telling you. They become so happy. So spend time if you really want to treat the patient conservatively. I'm not talking about the day one indicated cases for surgery. A patient will come with the large disc with deficit, you are not going to conserve in any way otherwise also. Now AAD healed with the conservative treatment. Now you see in first X-ray there is significant instability. Okay? Again, a child, the parents ask, can you treat it without surgery? Yes, we'll try. So put the patient on cytotoxin. You see this X-ray has been taken with the brace. Dynamic X-ray, 2 years follow, fully healed. Give time the instability to heal. Tuberculosis, we all know, is a medical disease. With sensitive AKT, everything heals nicely. Another, this boy, mother was a widow, and single boy in the family, whole family, I would say. And he was obese, has comorbidities, diabetes, hypothyroidism, and 112 kg weight. Now see here, it is almost collapsing, and cold abscess, everything. But what was good about this case, that it is a little bit angulation there, but in MRI, if you see, it is looking concentric. So these are the cases where we can wait. Or see, it has healed so nicely. Almost it has become a paired vertebra. Okay, so just time, just stress the need of horizontalization of the column, and they become all right. Now this is another case, 13 years old engineer. Actually, he was nephew of the then dean of KEM hospital. Slipped from a staircase, neurologically intact, spondylolisthesis of C3 over C4. Now fracture of posterior element of C1, C2 and C3. And that has saved him from neurology. You are seeing this, the spinal cord is looking quite all right, but the upper, all these posterior elements are fractured. One is fractured, two is fractured. Now here you can think very drastically that I will go for occiput to lower down fixation, because all posterior elements are fractured, and maybe some of the people may think, should I excise C3 and just align that? But with full explanation to the patient and relatives that we will try that, and if it gets aligned nicely, we will try to restrict the fixation for a less level. So I took again endoscopy, fiber optic, and we intubated. Patient is awake. That's why I have not covered his eyes. You can see his eyes are open, and this get aligned so nicely. And we just did that. Another, here you cannot operate the patient and leave him. Here the cervical spine has to remain in extension. You know, anterior plate is a buttress plate. Implant should always be put on the tensile surface, because this is going to be, suddenly it will go like this. More so if you have a 4 level. Other people will say he is a mad surgeon, he has not fixed it, such an unstable column. But with an open conversation, you tell him to ask whatever question he wants, but if he wants the limited area surgery, he has to keep in this position, military position like this, okay? And he maintained that. He understood his severity of the problem, he maintained that, and it has united. That's it, united, okay? Now this was the picture earlier, intact neurology throughout. Now previously practiced management strategies are well proven, practiced and followed, and this follows actually the essence of management. It should be taught, but all the junior colleagues should be knowing this. Practice and remain in the armamentarium or surgical tactics and procedure. Now, whenever you examine the patient, that is the time you teach them. You are going to lie down like this. Okay, getting up in this position is harmful. So all these things are very important thing. Now, earlier when these techniques came for, destruction of the pediatric spine and all those things, we were still practicing this, okay? Again, a senior person should practice, because here you have to compress and derotate the convex side. This is important, casting in EOS, okay? And these are all published thing. I am not talking otherwise. Now, this brace, it works very wonderfully. Though it looks cumbersome, but if you ask the patient and parents, they will say, no, if you are able to treat it conservatively, it is better. You can hold on, okay? Now, many of you might not be how the correction will occur in Milwaukee brace. The inspiration, it corrects the deformity. Remember, that's why that transverse bar should be there at the apex of the convexity. You are seeing this transverse bar is visible here. That it comes to the apex of the convexity. So every time patient breathes in, there will be chest expansion, and that will press the, that deformity to opposite side. So that's how this works, that is Milwaukee brace. Now traction. Traction is almost disappearing. In our unit was the only unit in KM who used to use this, and I specifically used to admit all female patients. My female ward used to remain always full. We used to occupy other unit patient also, bed also. Because a lady who is having severe pain, severe radiculitis, and you think it is just anti-inflammatory drug also, you will give just Ultracet. Now you can imagine how much is the action of Ultracet. You should give good muscle relaxant. So you must try to emphasize on horizontalization of the spine. Traction, it works wonderfully. Why I am so much for this? I had a cervical disc prolapse. My left elbow extensor had become weak. I put myself on traction. I took steroid. I became totally all. This is my grade 5 power. Grade 3 to grade 5 with traction medication. I had taken few days steroid also. So these things, they do work. And many times you will find the patient becomes all right. The acute disc prolapse, the surgery rate in my unit was hardly. It used to be just Cauda-equina syndrome and some significant deficit. I had given thesis to one of the PG. You know what happens? Your patient has back pain and he is in grade 3 or grade 4 power. And in the pretext of grade 3 and grade 4 power, you operate on the patient that you have started developing. But believe me, if you give traction, some dose of steroid, we also started using nerve stimulation. That thesis has been done on the. So at the pretext of grade 3 you are operating, let's improve grade 3. So we started stimulating common perineal nerve, and you believe me, many patients become all right, and their L3, their grade 3 became grade 5. So conservative treatment has a big role in. But you have a patience, and patients who also have a patience. Now he has to take the flight to go to USA, you cannot help. So all these things are there. My only thing is that it should not vanish from our armamentarium. This is very important. Now collar has a bad name because you have just written collar. Collar does not mean anything. If suppose he purchases a larger size collar, his pain will improve, pain will exaggerate, and that bad name will go to the collar. So there should not be any extension. His pain is going to further worsen. Here also, it should be a vector tension. Never give traction in extended position. Patient will worsen. His neurology also can worsen. Give in either neutral and little flexion, and these patients, they become all right. Now we are aware about this Kirkcaldy-Willis degenerative spine. Now, in which stage patient has come, usually you try to do that way. Remember, when he comes to the phase of instability, there is a pain, he will be willing for surgery also because he is in too much pain. The moment you wait for few days, give all these things, most of the time they improve. So acute pain is spasm, tablet Ultracet will not work. It is a half-hearted conservative treatment. Persistence of symptom will be there, and he will be pushed for surgical intervention. Rest, sitting in sofa and watching TV is not rest. Horizontalization of spinal column is extremely important. Bending and rotation should be avoided. So I'll conclude. Growth and development of newer instruments and implants should always be encouraged. Any newer tool implant should be thoroughly checked with adequate trial in existing perspective. The knowledge and use of conventional instruments, implants, and procedures should always be known, as sometimes it is of great help and might bail you out in difficult practical situations. I thank you very much for your kind attention and this opportunity.
Thank you very much, sir. That was a wonderful oration which we heard so long. I think beyond the professional brilliance, what makes Professor S.K. Srivastava sir outstanding and distinguishes from other people is his commitment and in the genuinity, and you have seen how passionate he is towards his patients and colleagues and also students. I think it is that integrity what actually made Dr. S. Rajshekaran sir himself to recommend your name for this prestigious oration. And we are very thankful, and we request a small standing ovation for the sir for the excellent oration. Sir. Thank you, sir. I will also request our President, Dr. YNR sir, and President-elect Narayan Rao sir, and Lila Prasad sir to just join for a memento. And may I request Rajshekaran sir also to just join for the memento, President. Just please take your seat. It's our privilege to have you here, sir. This was an excellent presentation.
Choice of Dr. Sudhir is not for the oration part of it, but actually for what he stands in the spine community. Actually, he's a different person in Mumbai. In personality, in his approach, and I think there is no other surgeon in Mumbai who has contributed so much to the goodness of poor patients and patients who really require spine surgery. Versatility combined with his skill and his ability to use these techniques. I mean, thousands of patients have really this thing, and so you will always have a place in heaven. So already booked.
Request our President YNR sir to hand over the shawl. Yeah. Sir. Yeah. So please join us, Narayan Rao sir. Thank you, sir. Sir, what do you want to do now, sir? So we'll break out for lunch and we'll come back with the sessions later. We'll quick lunch for gift from one more. A small moment of this symbolizes Amaravati stupa of our area. Thank you. We will just reassemble after 45 minutes of the lunch. Then we'll have discussions post-graduates. So, okay, whatever we want to discuss, we can discuss. Request the PGs to come back quick so that we can have some interaction.
Severity, yes. And so I am sure there may be multiple answers. But the purpose of taking history is you want to know what type of pathology this patient is having. Okay, that is the, so if you have taken history and you have not reached to a probable pathology, it means your history is inadequate. Probable pathology means what? Broadly, you should be able to know whether it is a congenital issue or acquired issue. Okay? Congenital, since birth, the mother will give history, this is birth. Sometime, the mother and father, they are not telling properly. They will say, he had a fall, and after that, he has all this problem. Just now, I examine a patient. So, since when you are having this problem? 3 days. It cannot be, because I am seeing the half side of the face is totally deformed, hypoplastic, the other face is, other side half is normal. It cannot be from 3 days. So, all these things in your background, you take history, and the purpose of history taking is to know what type of pathology it is. If you have not reached to that part, it means there is something missing in your history. Getting my point? So, you should be able to know whether it is a congenital issue I am seeing or it is an acquired issue, which may be in the form of, it may be traumatic, it may be inflammatory, it may be neoplastic, it may be degenerative, so anything may be there. Sometime you are not able to come to a conclusive thing, then you enter two possibilities, like it may be either infective or inflammatory. Okay, this is very fine. Okay, and always try to practice throughout your 3 years to know what type of pathology, then your history taking is good. Then you examine the patient, make your mind what I am dealing with, that is second. When you have examined examine the patient, you send for investigation, you should have something in the mind to search in that finding. Suppose you have examined the patient and sent for X-ray. Now yourself you should try to analyze what are the findings I am supposed to see. What are you thinking, and try to match your clinical finding with your radiological finding, and gradually you will see whatever you have thought, it is visible there. Why not directly MRI and X-ray? Because you will be seeing that area where you had got the finding. So your eye will go directly to that area and you try to search. Sometime I am seeing habit. As soon as the patient comes to the casualty, you write X-ray of the PVH, X-ray of the knee, X-ray of ankle also. Everything you have just asked. You have not properly examined the patient. If you properly examine the patient, if there is a tenderness on one side, that is the right facet of L5, L4 or L4, L5, L5S1, you will try to localize that area. That is the importance of that clinical examination. So, importance of history, you ask the patient, symptoms of the patient, it's what is the probable cause. Area of the spine which is involved, extent of functional affection, patient's expectation and concern. So you come to know all these things. You know, you are communicating the patient, you are trying to read the patient's mind also. Everything goes together. Okay? So history should be his story, not. You have to guide it. As a clinician, you guide it. And good history taking is a clinical art, you must master it. Okay, good history taking usually guides a clinician to reach a probable pathology. The probable pathology, as I told you, these may be broadly grouped into congenital or acquired. These may be the different varieties, and possibilities it may be either, as I told you, inflammatory or infective. That is very fine. Now, degenerative spine, you don't have patients to take good history. You also don't have, that patience to examine the patient properly, and just you see the MRI and you are trapped. Many times what is happening, patient comes with the MRI and he wishes that you see that. You stop him doing that. You communicate with the patient, take proper history, examine, then only touch that folder. Otherwise you are trapped. I will show you what is happening nowadays. A good history taking in degenerative spine gives you 40% information. Okay? Adding to examination further 40. So 80% you know about that patient. Only 20% you get help from the investigation. Remember, this is extremely important and that should be practiced. Now see this, a patient has come to you with this finding. Okay? Now you have seen, and immediately what you start, since you have been Now assisting since last 2-3 years, you start planning the surgery there itself. You start saying, okay, so many level compression and 3-level compression, there are many bulges, more at all 4-5. So you will require, you give a slip to the patient, you will require surgery. You have not examined the patient, okay? So this we say it is image treating surgeon quality. You should never do that. Always insist for plain X-ray. I am telling, plain X-ray, you must insist. Never examine the patient without taking history, and never see images without examining the patient. This is extremely important. And when you are examining, your knowledge should be in that grade that you are able to identify this. For that you have to read also, okay? So, eye does not see what the mind does not know. So, you have to do your homework properly. The moment you see the patient entering into the cabin, actually your examination starts from there itself. Okay? Though we have, bifurcated on different headings, you see the inspection, palpation, percussion, all these things, heading has been made. But actually, in fact, you start seeing the patient when the patient is entering into cabin. First thing you say his physical appearance and his gait. These two things, immediately you come to know what problem he might be having. Okay? And use all your senses. And the sixth sense is the common sense, which is very, very important. Okay? Now, when you see this child, you just don't concentrate on the spine because you are a spine surgeon. No, you have to see the peripheral part also. Okay? So, you don't concentrate here. You have to see patient's gait, head to toe examination, obvious deformity you pick up. Stigmata of concealed deformity becomes well. Suppose you have a tough hair in the child, and you see there may be intraspinal anomaly. Okay? And whether this patient is having respiratory distress. Okay? AAD case with conus compression, patient's nasal nares will be flaring. His sternocleidomastosis. He is using extra, normal respiratory muscles to gain that, oxygen concentration in his blood. So that's why he is in respiratory distress. And whether this patient is having any neurological deficit. Okay? Then you go to regional examination. The general examination is extremely important. This I already told. You must at least you don't say the physician only, why the physician only see the pulse, why not you? You must take the pulses. And suppose a case of spinal cord, cervical spine injury, and patient has significant bradycardia. Actually, it tells the prognosis is not good. Okay? Trophic ulcer in foot, altered attitude of the spine. The spine may be secondarily involved. The deformity is there in the hip and it is not in the spine. This exaggerated lumbar lordosis is not because of spine in this case, it is because of hip pathology. So you should be aware about all these things. And first you see the gait, whether it is a normal gait or it is an abnormal finding. Specific gait and tests are also described, but broadly there are two phases of gait, stance phase and swing phase. Broadly, stance phase means it is touching the ground, swing phase it is not touching the ground. Always the foot, normal foot is a plantigrade foot. Rest all are deformed foot. Okay? So these are the phases in that stance phase. Heel is strike. So first, heel has touched, then you foot flat, foot is lying like this, and then you mid stance means whole body is on that lower limb. So your foot may be touched like this, it may be touched like this. Both are different. Okay? The gait cycle, if you observe the patients properly. Now the importance of gait has become so much in cerebral palsy patient. Now they have gait lab and they try to analyze. Okay? So you should, as a clinician, should be able to pick up these. And swing phase, phase of acceleration, so you are getting up, then again mid swing, and then you have phase of deceleration. So these phases you should know and try to analyze which phase is reduced. Okay? So these are the common thing you should know. TB spine, it is painful, inflamed. So patient tries to restrict the movement in that area. Significant instability here, inflamed it is, he tried to stabilize like this, holding here. Earlier also you might have seen books also picture. Lumbar spine, patient puts both the hand on the thighs and walks like this. Try to immobilize that area. PID and patient has ankle or foot drop, there will be high stepping gait. Posterior column, suddenly as if he is walking in a dark room, suddenly he puts, because posterior column, the sensory track is involved. Now this side go. Now this is for you. Second, what are the things you inspect in inspection? This is just whether you are practicing it or not as a PG.
We inspect for deformities, sir. Any deformities?
So that comes under attitude. Attitude of the limb. Then?
Swellings.
Swelling.
Scar sinuses.
Skin condition. Now, Dr. Naresh, I think he has to show some case. I can stop because he is in flight. So, no, what I am going to be here for more time. You can show so that you are free. I don't want that you should miss your flight. It is because I know your flight is, you plan to go at 3 o'clock. Because this might take, if I am asking question, then it will further take more. So, Dr. Naresh, you can attach his thing. I will stop. Maybe we will start later on. Yeah. So, actually, whatever area of the body you are examining, inspection 5 points are must. You will not miss anything, I am telling you. The first you told, attitude is first, whether deformity is tilting like that, he is forward bended walking. So, everything will come in attitude. The second is swelling. Third is skin condition, where everything comes, scars, sinus, all these things would come. Muscle wasting, you will not, many a time you miss this muscle wasting. And that is the only diagnostic thing for something where it is causing suppression of the function of that muscle. And then limb length discrepancy. Okay? So these are the 5 points, whatever area you examine, the cervical spine, dorsal spine, lumbar spine, everywhere this is the actually sequence you should follow. I think I will discontinue. Okay? Yeah, Professor Rajsekharan, you please go ahead. You can.
So we'll just go on to 1 or 2 more cases, and then because this time we thought we'll keep a case-based discussion. No? So this is an elderly person, and so you can see that she has got a major problem. Definite instability over here, and this is a very important sign which all of us must know. And just now I was talking to Sir. When you have a doubt of whether you have an instability or not, in some subtle cases this is too obvious, because whenever the bone is moving this way, the superior and anterior part gets destroyed. But in many of the other cases also, you can see that a small part of the anterior part would have got destroyed. It will not be as sharp as it is over here. That was in a very good case which we discussed in the lunchtime. That means there is a lot of instability. The second major important thing that you have to see is, you see when you do an MRI, you are not able to see the vacuum sign. Yeah. So in still or in flash study, if you look at, then you can see this vacuum sign shows 2 or 3 things. That means that there is an extreme disc degeneration. The disc is completely gone, the matrix is completely gone, and vacuum sign does not come in the absence of instability. So that also we have recently published in European Spine Journal. Rishi as the first author. So this is obvious, but even in subtle spondylolisthesis, you have a doubt whether there is instability or not. Then when you do an extension view, in the X-ray you will find that the vacuum sign appears. It will not be present in flexion view, it will not be present in normal view. And in the CT, obviously you will see that there is a vacuum sign, which means that there is no role for just doing a discectomy or a laminectomy or something. You have to definitely go ahead and do a stability. So this is an extreme form of instability with osteoporosis. So what will you do? Come, somebody? Anybody from the second row? There are a lot of ladies, actually we have not asked any bold lady. Otherwise I'll ask the same victims again. Come, what will you do? You just tell the principles. Oh, that is fine. What all do you think is the risk factor here? Number one, osteoporosis is a risk factor. Good. The second is, what meant? Obviously what? Instability. Major instability. It's not a small time instability. So it's a very major instability. Yeah, third. Yeah, she had not a big neurodeficit, but the third is when you have this sort of body, then how do you put a cage? I was just telling, no, anteriorly it is opening. So when you are hitting your cage, you go a little more, it will just fall into the vacuum over there. And in the posterior it is very small. So in these cases, what you will actually find is you need to look at the CT very carefully. At some point there will be a good end plate, and other places, at some areas if you have an intact end plate, then you must target your cage in that position. Because very difficult to put just a bone graft over here, it will not get consolidated or fused. So this was done in 11/20/1/24. So what do you think about it? It's okay or not okay? It looks very good, huh? But anyway, this spine did not think it's very good. So what are all the risk factors here? One is you absolutely need to have a good stability, otherwise these cages will fail. But when you have such a big osteoporosis, and then this may be a little flimsy as it is, then a single point fixation will not be sufficient. Actually, at the time of placement, I mean, it was done by one of our colleagues in our hospital only. They said they were really surprised that the cage was holding so well. But if we had, I think, gone one more level above, we could have got away with it. So this was there, and then this person came 3 months old, and you can see everything has fallen apart. So the cage has moved because I think it didn't have a very good thing, and this has also cut through. Everything is loose. Nicely it has become loose. So now what will you do? So what is the learning point over here? So just one level above fixation is sufficient only when everything else is good. When the end plate is good, your bone quality is good, and your cage fixation has been good, and not when you have this is what I call as a trumpet deficit. It is narrow behind and opening in the front. That's a very big risk factor for whatever you do. In those cases, you should not hesitate to add more levels. You will be much safer. So after that, this was done. And you can see that we have added one more level, but also added, yeah. So actually I would have felt a little more comfortable even if you had gone one more level also. But anyway, 4 to 7 is what? 1 year, 3 months. Now she is stable, then she is stable. So this is an important learning point, that you should not be conservative in your levels. Whenever things are not completely okay, you should not hesitate to add more levels when you have to go. So Sambasivara wanted a vertebroplasty case. So what is this patient had vertebroplasty 3 months ago. And when she came to us after she had the vertebroplasty after 3 months, she had more pain. She said now she is not able to be straight and she has pseudo-paralysis. So when she is lying down, she is completely normal. But when she gets up, she feels very weak and her proximal muscles were buckling down. And this was rapidly increasing within 10 days. So she came and saw that. Anybody? Samasaro, it's your favorite, so you have to say what do you think is the problem.
That posterior aspect of the bone is still compressing the probably. Yes, sir. Yes, sir. And most probably instability is there. Crocodile sign might be there, sir.
So there is a progressive kyphosis happening. So when she is lying down, it becomes straight, so she gets normal neurology. But when she stands up, there is a kyphosis which is there. Anybody else? Anything different you see? One more important thing is there. Yeah. So that is what. So you can see tracking over here, there is something there. So there is a cement extrusion into the canal. So this is the CT. CT is the best thing to take it. But there is one saying, acts of omission and commission, but God is kind. If this is happening, you will think that this patient is going to become paraplegic on day 1. So nothing happened. I mean, so much of cement extrusion coming all the way till here, and cement will burn thermogenic also, no? So it should burn, but this patient actually woke up comfortable, not much pain for the first 2 or 3 weeks, and then the whole thing started because it was collapsing at this part. So you can see that it's not fully consolidated here. So that's the main reason. So now what will you do? That has to be removed at any cost, isn't it? So you look here, how much cement has extruded. So this lady is very lucky and the surgeon also is very lucky, otherwise there would have been an instantaneous this thing. And if you take the cross section, you can see it is fully. So you have to be very careful. One of the things that you will be very careful is if in the CT with MRI alone, you should never do a vertebroplasty. That's very learning point is with MRI alone, never do a vertebroplasty because you need to know whether the posterior wall is intact or not. You can do a vertebroplasty even if the posterior wall is slightly gone, but then you will place your the needle point over here. At this very tip, you have to place your needle point and then gradually just mainly inject after the cement has become almost near setting. So you should not be hesitant to waste cement if it is not there. If you put it as a liquid and if you press hard, then this is what will happen. It just has to find one and in a minute it will relax. But here there is a problem. You see everything has been there. So you should always get a CT scan to do it. So when this lady actually stands, the whole thing presses and then she's getting paralyzed. But this is the time to take it off now. So we just put multiple screws because we don't need to allow it to kyphose again. And then we actually remove the cement. So because there was very little space between the lamina and the dura, when there is very little space, if you put a 3 or 4 millimeter kerosene, then you will get again neurological deficit. So you have to thin the lamina as much as possible so that you are using only one, or we are using only a one upcutter here, so that you are sure that you are not pressing on the This is also a very important point. So in the presence of neurological deficit or very tight compression, so don't put a 3 or 4 millimeter kerosene. You will get a neurological deficit. So we are removing the full bone. So once you remove that, so you can see now the thick block of cement. You have to be very, very careful when you remove it. If you pull it as a block, then it will tear the dura and come. So we are cutting the cement into thin pieces with an ultrasonic cutter. So gently cut it and then move it bit by bit. And you have to have a neural monitoring. COC, we are cutting it into small pieces so that it will become loose. You have to be careful, otherwise the patient will say that surgeon did a good job, this surgeon made me paraplegic. So I'll just go through this fast. Don't pull at all. Slowly release, slowly release, and then take it out. That's a very big piece. There is also another big piece there. So again make it into thin pieces and then take it. Don't take it as a very big piece by itself. You see, it's stuck to the dura, so you must be very careful. Yeah. Underneath there is still another big piece, so that's it. So once you do that, then you can see that it's not going to the next slide. Yeah. So this is all the huge pieces of cement that was removed, and then we have done a fixation also. Then that becomes a this thing. The other important thing is when you have to decide between whether just vertebroplasty or whether you will also fix, you have to remember the AO spine, TGOU, osteoporotic classification. So this is it. But whenever you come to 3 and also 4 and 5, that means there is an inherent instability there, and 100% you have to fix it. Because if you don't fix it, then the cement moves this side and that side and you get into a major problem. So that is it. Yeah. So if you are beginners, I will just put a small video of what to do with vertebroplasty. Position and draped. A gentle pressure can be applied on the site of the fracture, and this will help to open up the wedged vertebra adequately. You can see here that there is a good opening of the vertebra subsequent to the pressure, and the pseudoarthrosis lesion is more clearly visible. Next is the placement of the needle, and it is important that the starting point must also be planned always with a good AP view. The CR must be so positioned that the end-on view of the pedicle is very clearly seen. A forceps can be utilized to mark the extent of the pedicle, and a stab incision is made so that the needle can have an entry point on the lateral margin of the pedicle. The entire success and safety of the procedure is on the accurate placement of the needle through the pedicle and into the pseudoarthrosis mass. As explained before, you can see that the tip of the needle has been placed at the lateral margin of the pedicle, and then by gently tapping, the needle is progressed appendicular skeleton. Once the patient is positioned and draped, appendicular skeleton. Once has been placed at the lateral margin, tip of the needle must have crossed the pedicle
before the needle has crossed the medial margin of the pedicle appendicular skeleton.
So this is very
Once the
important.
patient is positioned and draped, a gentle pressure can be applied on the site of the fracture. Pedicle and into the pseudarthrosis mass. As explained before, you can see that the tip of the needle has been placed at the lateral margin of the pedicle.
This is very important to start at the lateral margin of the pedicle and not the middle of the pedicle. And before it crosses the medial margin, on the lateral view, it should have crossed the pedicle into the body. That's very important.
The tip of the needle must have crossed the pedicle before the needle has crossed the medial margin of the pedicle in the AP view. And secondly, the direction of the needle must be so positioned that the needle tip will be accurately reaching the pseudarthrosis. This moment,
So here the pseudarthrosis at the top, so you should go towards the top.
be confirmed. We can see here that the position of the needle tip is in the pseudarthrosis. And this can be confirmed by also introducing a thin stellate through the junction needle. And it will be seen
just drops into the pseudarthrosis.
The procedure is repeated on the right side. A forceps tip is used to identify the lateral margin of the pedicle, which will be the entry point for the needle. Again, by gentle taps, the needle is passed through the pedicle, confirming on the lateral view that it has crossed the medial margin in the AP view.
So both the needles are going exactly into the pseudarthrosis mass.
It's confirmed, and again by gentle taps, the needle tip is positioned into the pseudarthrosis space. The thin stellate is again dropped into the pseudarthrosis space for confirmation.
Just drops into the pseudarthrosis mass. The second way you can confirm is by injecting saline into one end, the other end will.
Position of the needles can also be confirmed by injecting saline into one of the needles and confirming that it is flowing out through the other needle. This procedure not only confirms the position of the needles, but also allows washing out of the pseudarthrosis and cleaning it for cement injection. Once this is done, the saline inside the vertebra is sucked out from both the needles, and this will result in a pneumogram of the pseudarthrosis.
You can see the air inside, so you know that it is perfect.
On the lateral view. At this stage, the cement is prepared by mixing the polymer and the monomer, and while it is in the liquid stage, it is filled in 2 cc syringes, taking care that there is no air bubble within the cement. Although only 1 to 3 cc of cement can be injected usually into any one vertebral segment, it is usual to fill 5 syringes just to keep things ready in case it is necessary. The cement should not be injected too early when it is in the appendicular skeleton. Once the patient is positioned and draped,
I don't know why it's jumping, but then you have to.
appendicular skeleton. Once the patient is, when it is in the liquid stage, as it will tend to flow out of the defects in the vertebral wall and extrude out either on the circumference or more dangerously through any fractures on the posterior wall of the body. The chances for pulmonary complications due to monomer infiltration into the vasculature are also very high when the cement is too liquid and injected at this stage. Placing the syringes under the surgical light will help to fasten the setting of the cement due to the warmth of the light. When the cement is found to be of correct consistency, It is then injected gently under fluoroscopy, initially to make sure that the cement filling is in the correct space and without any extrusion. The needle opposite is kept open without a trocar so that it acts as a vent. The quantity of cement to be injected is determined by the sensory feedback on the pressure required for injection, and also critically viewing the lateral view, which shows the completeness of the filling of the defect. A few images on the lateral view should be taken successfully during the injection to make sure that there is no extravasation of the cement into the canal. At this stage, an AP view is obtained to see the filling of the cement. Here it is seen that there is less cement filling on the right side, and so the cement is now injected on the right needle with lateral fluoroscopic guidance. It should be emphasized again that any cement injection should be done only with the lateral image control, because prevention of extravasation of the cement into the canal is more important than extravasation on the lateral side. The trocar is introduced into the needles on both sides so that the cement tract is obliterated and both the needles are removed. The AP and the lateral view will show the status of the cement filling, and also here we can confirm the absence of any extravasation. The pin tracks are closed with a single stitch, and a small dressing can be done, which completes the procedure.
So any other doubts on vertebroplasty, this thing? If it is not opened out completely, as I said, after you place prone, many of them open out by themselves. You can just apply a little bit of pressure, then it opens out. Even then, if it doesn't open out, then kyphoplasty may be necessary. Dynamic curves. Just fix it like that, you're saying? Yeah. You know, but when you saw that in some of the areas, the space available was so low, then it is there. So this patient, what I think you're asking, because what happens if there is a neurological deficit when you remove? Is that why you're asking? Yeah, so we are doing it under spinal cord monitoring. So when you are moving or doing something, there is alteration in the spinal cord, we will stop and then just fix it. But it is better to remove the whole thing, you don't know, yeah. That is also okay. Yeah, the one needle if you use, then it is not venting, no? So there is, in that cavity there is something. There is some water, saline, or some fluid, body fluid is there, or some debris is there. So when you are pressing hard, the cement, if it has to occupy that space, it has to displace something over there. And when it displaces the fluid and the debris and other things, it will open up to all these fracture spaces and the cement will go. So you want, when your first cements to go, there should be equal space for everything else to come out. Even if it is air, it has to come out, so that it will go and settle down over there. So keeping two needles is very safe. You need a vent. Just like if you are going to put an interlocking nail into the pathological fractures, pathological lesions, without a fracture, you have to vent the distal femur before you put the nail. In closed spaces, you cannot inject anything. Yeah? Good. So I'd like to thank all of you for this excellent day, and till we see next year.
One more, Professor Asar. One point that sometime if you have a doubt, you can put a dye first and see whether it is leaking posteriorly. In that case, you will not choose for that cement, or maybe gluey when it becomes, then only you put under CM control. dye is one thing which can use for knowing whether there is a posterior opening.
So dye is also very important. I don't know how many of you inject it into acute fractures. We don't normally do, 95% or 99% of our injections are only into pseudoarthrosis. But there are lots of institutions which inject, especially in the Western world. Patient comes in, they are all living alone, old ladies living alone. Acute fracture, you can't say take rest for 3 weeks. So acute fractures they inject. There, what Sudhi said is very important. You have to use a dye to see where all it is leaking. Major leaks are there, then you will avoid vertebroplasty. I mean, there are so many instances, this looks bad, but there are so many instances where they have found big chunks of cement in the right atrium. So you are injecting, it just goes out, gets into the vein, into the inferior vena cava, common vena cava, and then into the right atrium, right ventricle. So many places the cement is found. That's dangerous. No, we don't usually give a brace. Unless for other reasons you want to give a brace, then this is okay. But you should start put them on osteoporotic therapy. That's very important. Okay, good.
Thank you very much, sir. That was an excellent day, and we are all deeply indebted to you for taking all the time and coming over here and talking for so long, simply standing. I think it's 4 hours, sir is continuously standing and then giving the lectures. He needs a standing ovation, and it's our pleasure to hand over a small memento from President and President-elect Narasimha sir to comment. Sir, please accept our. Lila, join. So we also bought a gift for Pushpa. We are missing her. So we are handing over to you also, that also to you. So
Dr. Pushpa could not come in the last minute because her father suddenly had a hepatic failure. So he is in the ICU. So she couldn't come right now.
Father's speedy recovery. Thank you, sir. It was a great day. Thank you. So please, we'll continue with the sessions. I'll request our Srivatsava sir to carry on with the examination of the spine. Sir, you'll just continue with this. Sir, just forgot one Buddha statue also. You just forgot the one more memento. Sorry, Buddha statue.
Yeah, so actually we were discussing about this inspection. So all these 5 points you have to see whatever region of spine you are examining. Maybe appendicular area of the body also same thing applies to. Sorry. So inspection, so you see all these things. So in this case again, when you examine the patient, you examine from back, front and sides, and they are the important areas you have to expose it. And maybe you need not, ladies patient, you should keep one lady attendant, and at least required area you have to see properly. So necessary exposure is vital. Examine from back, side, front in standing, lying down and sitting position. This might not be possible because of the situations there. Maybe it is very painful. In that case you have to examine the patient in lying down position, but still you can turn the patient and examine that area. So there are the different things you might find in attitude. There may be torticollis, and see this is actually bony torticollis. You can see the anomalies there. And if long standing, you notice the facial asymmetry. One side of the face becomes hypoplastic. Sometimes their gaze also, it gets tilted. And sometimes these patients, they have diplopia. Since they are able to speak, they will not tell you, and they are able to see, so they might not able to not tell you as a symptom, but you should ask necessarily, is there any problem in the vision? That is important, okay? And you might find abnormal sagittal contour, and lordosis may be obliterated in cases of acute problem. There may be kyphosis or hyperlordosis. Now here, this patient has a flat back, the lower lumbar spine, if you see, there is almost a flat back. And there may be hypokyphosis or hyperkyphosis. There is a hyperkyphosis, okay? There may be scoliotic curvature. And when you are seeing this, immediately becomes obvious that this patient has so many deformities. And then each part of it you must try to mention. This is important when the patient follows up, like a case of adolescent idiopathic scoliosis. Now patient is growing, so similarly today if you see after 6 months, there may be change. So unless you have mentioned that, how do you compare? This is important, okay? So see that there may be localized deformity, which I think you might have seen by now. There may be knuckle deformity. When one vertebra is collapsed, one of the spinous process becomes prominent, and you say knuckle, there may be 2-3 involvement that will lead to angular prominence, and many involved, then it is known as gibbous, okay? Now this. Now sometimes you find such type of cases also. So it is not only the scoliotic tilt or lordotic, or there may be component of rotation also. Okay, so these things should be noticed. But when you are planning to do this, and these the contribution of this deformity may be at multiple places. It may be in the spine, it may be in the pelvic area. Sometimes patient has limb length discrepancy, he tilts just to maintain that leg length. So all these things are very, very vital, and you must mention on your paper. The list is pure planar shift. There is no component of rotation. So that's how you differentiate, okay? So when you examine, you see where is the major curve. So see major curve in the thoracodorsal area, okay? Thoracolumbar area, it is going down. Lumbar area is having compensatory curve, and then you might be having in the cervical thing also. Now here if you see, both the scapulae are at different level. That's why I have been marked. Okay. Here there is a flank, there is a crease. There is a crease in that side. That is the site of concavity there. And you see you try to plan and try to see that how is both the truncal shape. So one side there is a chest, there is a convexity, another is a plane. So these things should be mentioned on that. Now, can anyone pick up what is there in the upper dorsal area? Any one of you? There is hypokyphosis of proximal thoracic area. You are seeing this? Normally what happens, there is a kyphosis in dorsal spine, but higher up there is hypokyphosis. That side is, and all these cases, we earlier, during our student days in MBBS, people used to always say it is kyphoscoliosis. No, most of the time it is lordosis of thoracic spine. What prominence you see, it is the rib rotation. Okay, rib rotation, and because of that rib deformity, from the side it looks as if there is a kyphotic deformity. Okay, so that is important. So there is hypokyphosis in the proximal area, you can see here. Then you do Adams forward bending test. So there the rib hum, it becomes prominent, okay, and this is the area which gives you impression whether this patient has kyphosis. Practically it is not kyphosis, okay, it is because of the rib hum, and there is a associated chest deformity, and you draw a plumb line, and many a time you find the patient's shoulder is all right, patient pelvis is all right, in between there is a compensatory curve. So you are not, sometimes it is not obvious when the patient is wearing cloth. So it looks that there is no truncal deformity, but it is because of the compensatory curve. And swelling, there are different types of swelling which you might encounter. In newborn you can have meningocele, meningomyelocele, localized bony prominence, there may be localized swelling, there may be paravertebral abscesses, fibrofatty tumor, lipoma, osteochondroma, or sacrococcygeal tumor. Now this is in the lumbar area. One side the lumbar area, there is a swelling. Again it was a cold abscess. It is in the dorsal area, paravertebral area. And now see, when this patient came, so if you see the first picture, there is actually dilated veins also. So the intern brought this patient, this is a case of tumor, thinking, that there is a veins which is very prominent, very significantly swollen. So then first thing I told you, have you touched the swelling? Okay, so it is a soft swelling, it is fluctuant, so it cannot be tumor, so this is something else. And you see here, this is actually tracking from the lumbar area. If you wear this, actually X-ray is not very clear, but you can make out that L4, L5, the disc space is significantly reduced. So this patient had cox spine, and this has tracheal so much so in the thigh area. Okay. Now all these swellings are not abscess. So you come to a conclusion that this is a fluid only after doing full test of fluctuation and all things. Sometimes you can have a former thing. If it is in the dorsal spine, it doesn't mean that this is pot spine and there is a cold abscess. No, you have to properly examine that right from inspection, palpation, all point of swelling has to be actually looked into. You will be surprised to know that this was a case of rhabdomyosarcoma. Okay. Actually, the field itself was not like a cold abscess or anything. So all white structure which is seen is not cold abscess. Then skin condition, I think many of you might have seen such classical picture. If you have a hairy patch, also known as fawn's beard, okay, it is seen that it is commonly found in spina bifida or underlying cord abnormality. Now you can see here this patient has diastomatomyelia. Okay, there is a split cord and there is some septum which is growing from front to back. Okay, how will you differentiate whether it is diastomatomyelia or diplomyelia? Can you tell me? Yeah, and there is a septum. Either it is a soft septum or it is a bony septum. Okay, diplomyelia, it might have single sac in which there are two cord material. So that is diplomyelia. Now, spot diagnosis. I think many of you might have seen in undergraduate also. Oh, so cause is neurofibromatosis, cephaloid spot or nodular skin swelling, it is neurofibromatosis. Okay. Then you assess about the muscle wasting and asymmetry. You must see, because these are the area, the gluteal area usually you miss it because you never uncover and see. If you have any doubt, you must uncover and try to see scapula, deltoid, Hand wasting is very clear, okay. The case of myelopathic hand, then you have other etiologies, classical, myelopathic hand, you will have motor neuron disease, all these muscular dystrophy, all these cases you should try to at least notice these, okay, facial asymmetry, truncal asymmetry, and then you examine from the side. So this is the first thing you see, how is the alignment of the colon, as you have seen from the front, whether it is tilted or bending one side or any deformity, you see also the similar thing from the side. And normally a balanced spine, if you draw a line, it will pass from pinna to shoulder to greater trochanter to lateral malleolus, straight line. It is a balanced straight line, okay. So that's how it is aligned. Normal, you can have normal lordosis in cervical spine and lumbar spine, and kyphosis in dorsal spine and sacral area. The abnormality in sagittal contour, there will be loss of lordosis. Painful condition, there is a loss of lordosis. This is snipping position, okay. So there, actually the kyphosis is there in the cervico-dorsal junction, and that's why the whole cervical spine is throat and the front part, and this patient may be having the early feature of ankylosing, okay. And now here this established case of cervical kyphosis in case of a ankylosing spondylitis, okay. Now here again, there may be Sherman's disease can lead to kyphosis, ankylosing spondylitis, tuberculosis, congenital deformity, trauma and osteoporotic fracture. So these many may be the causes. So that's why I told your history should give some clue what type of pathology this patient is having, and of course you are going to examine this patient. Hypokyphosis may be compensatory or post-surgery flashback can be there. There may be associated chest deformity. Suppose some lung surgery has been done in childhood. These kids, they might develop some deformity because of problem inside the chest, okay. That also used to be visible when patient, had to undergo pulmonectomy and all. It is not talking about these days. Earlier, they used to have scoliosis because of the fibrosis of the content of the chest area, okay. So there may be abnormal contour even the lumbar spine, flat back, kyphosis, hyperlordosis, or also known as sway back, okay, like this, okay. And again, it may be related to your spine issue or hip issue, okay. And always try to, body tries to compensate that. See how he is trying to maintain his center of gravity there. So he is flexing his hip, okay, slight flexion at the knee and slight forward bending. So always patient tries to align his alignment in the sagittal plane is compensated, okay. Now you are examining from the front, okay. So suprasternal notch is the midline, center you palpate, and both the iliac crest, anterior superior iliac spine. So that should be in the center, and you are able to see that they are at the level, okay. Then you see this is sternocleidomastoid mastoid. Again, it makes a triangle anterior like that, okay. It meets in the suprasternal notch, okay. Then you see about the sternum, see about the level of the shoulder, okay. And costal ridge you see, then you see the flank. Sometime if there is scoliosis, one side distance from the trunk and the arm is different as compared to other side. So that gives you there is some tilt and the limb is away from the truncal area, okay. Truncal shift has to be seen, level of the umbilicus. If patient is very obese, this umbilicus actually maybe because of the pendulous abdomen, it might not be giving any significance, but you at least look for that lower limb length, how is it, swelling, skin condition, wasting, everything you are going to see, okay. Gross deformity of the whole world, where to start. So here you need not examine each and everything, and we don't expect that in exam you do this. You actually try to see the pathology, what type of pathology it is, and what is the functional disability of the patient, what patient is going to gain after even treatment, okay. So this is important. Those point you need not miss and you should not miss, okay. Now here on palpation, all the muscles were converted into bone. Mouth opening was negligible. Actually, he was able to just sip or drink water, drinking that to with a straw. He was not able to open the mouth. So this is a very classical case of myositis ossificans progressiva, the very unique case where all the muscles become bony. And you can see the paravertebral muscles, you are seeing from the back, it is bone, all bone. He is bent in that position and fixed and fused in that position. Okay. Then you start palpation. Always start with the local temperature. See the local temperature from the back of the finger. The standard, I think all of you know this, and there are different way you do superficial, deep thumb, and another rotation. Now you cannot palpate the anterior part of the vertebra. Body is not palpable. You cannot palpate anteriorly. So what is the way? If you some etiology lying anteriorly, you try to rotate and see whether it is producing some pain. So when you try to do that, there may be rotation and patient might have pain. Thumping, why thumping? Because thumping, it transmits that force to the anterior part of the segment of that vertebra, so that if it is inflamed, patient will have pain. So these are the different way. Again, when you palpate this swelling, start from the how many numbers, size, shape, consistency, whether it is fluctuant or not, what is the origin, how is the mobility, and whether it is pulsatile or not. So all these informations are extremely important. Okay. I just want to quote a case. The patient was having severe pain in the thigh area, anterior part of the thigh area. And he, coincidentally, the person has thought that he is a case of radiculitis of lower limb. The MRI was taken and advised disc prolapse is there, that's why you are having radiating pain and you should undergo discectomy. And that patient's maid servant told ki you would show to sir also. That patient came. He was febrile also. And where is the pain? So pain in the anterior aspect of the thigh. Nobody had bothered to see thigh. And thigh there was abscess, pyogenic abscess. Can you believe this? This happens. And happens in the city of Bombay. Okay? So you have to be very, listen to the history. He is telling pain in the thigh. At least open the thigh and see what is there. At least you are going to examine the sensory dermatome or not. The L3 is there. You have to open it and see the sensation. This is too much. This happens when you see the MRI first. Okay? So this is very, very important. Okay? And movement, always, don't miss it. Sometime while examining, you will come to know the here is significant restriction. Even if you don't touch the patient and ask to move his cervical spine. If he does like this and not going to full range of rotation, it means there is some problem. So all these ranges are given. Some of these things, it varies from person to person. That also you should be aware. Many of these persons who are there absolutely in office job, sedentary work, you will find their hamstring is always tight. It doesn't mean that they have positive SLR. Okay? So this also variable, but this is the rough guideline that this is the normal range and where there is restrictions or not. Okay? Movement of thoracic and lumbar spine. Now, you know this area is, when the hip is associated and contributing to the flexion, and you try to ask the patient to touch the ground, at least he should be able to reach within 10 centimeters of the floor. And the contribution of lumbar and thoracic spine is actually there. You can do actually in sitting position also, like actually rotation of the spine, you should make it patient sit and ask them to rotate. Okay, so the rest of the area is obliterated. It is the pure rotation in that area. Okay, make the patient sit on a stool or stabilize his pelvis. Extension is approximately 30 degrees. Maximum theoretical range of thoracic is 25 and lumbar 35. Now remember, thoracic spine, it contributes significantly to this rotation. Okay, because the lumbar spine facets are in sagittal plane. It doesn't allow too much of the rotation. That is one. That's why when you are fixing a paraplegic patient, they are shifting from wheelchair to bed and bed to wheelchair. This rotation is very important. So don't fix unnecessarily and don't include too many segment of thoracic spine. It is vital for them. Try to maintain the rotation in the thoracic spine if you are tackling the case of paraplegics where there is a significant neurological deficit. This is about the lateral bending, and as I told you, rotation in sitting position, apparent change in the length. Basically, when you have a stiff spine, you have ankylosing spondylitis, you see this, okay? Vertebra prominence to sacrum, and this was classical of Schober test. Modified Schober test, you don't practically take the measuring tape from top to bottom. Here, what we do just keep a stretched palm, okay? One line in that lumbosacral junction or S1, S2 area. You draw a point 10 centimeter below, 5 centimeter below, and ask the patient to bend. Just spread your finger will give you that he has adequate range of movement, and that will definitely informative for you. Okay. So this is modified Schober test. Single leg hyperextension. Actually, if the patient has significant pinpoint pain there, it actually diagnoses lysis in that area. But it is not classically only lysis. Sometimes in the facet joint acute inflammation, it might match because this lysis and facet joint is very nearby. Okay. Chest expansion in all cases of this ankylosing, this is important, and if it is less than 2.5 centimeters, shows sign of restriction. Okay. Now, these tests, upper limb tension test, actually, it is not that kept into practice, but it is for a postgraduate student, you should know. As we have SLR, femoral stress test for lower limb, we have for upper limb also. And this is known as UTT 1, 2 and 3. Now you see the difference. Now upper limb tension test 1, here actually the examiner, he stands in the axilla of the patient. Seeing this? Practically what we do, we try to stretch that specific trunk of the roots. You are stretching that. Similarly, you can stretch. So median nerve dominant, you will be stretching the 5, 6, 7. Now see what I am doing. I am hyper extending the elbow. I am extending the wrist. I am further even extending the fingers. Okay. Now this here, I am standing outside the axilla. I am standing near the shoulder area. So it is actually given in clinical examination books. You try to understand this. So, and then they had two components, 6, 7 was here, and lower down, if you go lower trunk C8T1, this is upper limb tension time 3. So again axilla, okay. So 1 and 3 you are standing in the axilla area, and 2 you are standing outside the axilla, you are standing in the shoulder area like that, okay. Here see what I am doing. I am trying to flex the elbow and hyperextend the wrist and fingers also. Okay, so this is important. Now I think many of you might be knowing all these things. This is important if you have a pathology which is involving cervical spine. You just give a little jerk, but one has to be careful, and you must know. This patient is not having neurological deficit, and instability can worsen the situation. So axial compression, patient gets classical radiating pain in that particular limb. This is known as Lamit sign or maneuver. Okay. So here what sometimes this is pronounced in a different way. The best is Lamit sign, as the people say. Pronunciation is little different, and sometimes you have a reverse of that, and that is known reverse Lamit sign. So here what happened, sorry, I am going to tell you in maybe in next slide it is there. In myelopathy, if you try to extend, again there will be excessive pressure and patient will have. So that is known as reverse. You are not flexing, you are extending the spine. Okay? Now this is again, you are stretching the dural sleeve. So if it is inflamed, patient will have pain. Both the signs are described for that. This is Valsalva maneuver, where you try to increase the intracanal pressure, and then if any mechanical compression is there, patient will have exaggeration of pain, and you say it is positive. Forced exhalation against a closed airway. Milgram test. Again, when you ask the patient to raise both the legs together, what will happen? There will be increased pressure inside the canal, and again patient will complain of pain. Knapf-Ziegler test. So routinely, even though you don't practice it, but all these things you should know, because in examination you might be asked about this. Pressure on jugular vein bilaterally causes pain in cases with the herniated disc. Okay, or there is a regular hour cross SLR, then straight leg raising test, which is always a passive test. Remember, this is a blunder if you start lifting you ask the patient to lift the limb. Okay, so it is a passive test. Active SLR tests what? Same, I am going to ask you only. When you say the patient to do active SLR, huh? I am not talking about fracture and all. Fracture patient not, that is not I am asking. Active SLR for spinal pathology. SI joint. SI joint test is where you ask the patient, SLR patient will have severe pain. Okay? So remember, passive SLR for stretch sign or disc lesion or some any other lesion where this root is getting compressed, mechanical compression is there, and when you are stretching the root on that mechanical compression, patient has a pain. Okay, so this is passive SLR. What we perform for disc is a passive SLR, but active SLR is for SI joint. Patient will not able to lift it; it will be painful for him. Okay. Well leg raise test, again it is cross SLR. Normal limb, but you can sit. Normal limb if you lift, okay, and again patient has pain. He was not complaining of radiation to normal side. He was complaining radiation to the affected side, which he initially complained of. But if you raise it, it means either there is a very large central disc prolapse. Okay, sometime it might happen. Okay, and then you reinforce this by doing the ankle dorsiflexion. You raise it, then slightly dip it, it will become less. Again, you accentuate this stretch by dorsiflexion. Then patient will have again wins with the pain. Bowstring, you try to press in the popliteal fossa. The same nerve is coming down. Slump test, here it is done in sitting position. So it is like a classically you are doing SLR in sitting position. I will say, sometimes you have so many patients in a bed that examination coach is not empty. You make another to sit on the stool or chair, ask him to just raise like that. Okay? And here just try him to dorsiflex, he will have pain. So this is our like SLR in sitting position. Okay, so this is quite useful in OPDs. You can do that. And you see here the accentuation I am doing further, bending the knee also. And see, you are asking him to dorsiflex. Okay, tension sign in sitting position. And this is for the femoral nerve stretch, because femoral nerve it passes from the front. So you are doing the reverse thing. Okay, and when you are doing neurological examination, this should be the order, and you try to tell in exam in this order: higher function, cranial nerve, tone, power, reflexes, both superficial, deep, and sensation. You should know the root value of that. I am aware that all of you know this, and you should. Why? Because after your presentation, the examiner will ask you which is the neurological level. He will definitely ask you what level it is. So how do you decide the level? Affection of neurology, motor, sensory. Okay? So these are important, and you should know C5, which muscle you are going to test, what reflex you are going to test. Okay? C6. C6 like this. Okay? This is the figure 6. This is the figure 7. So this is C7. This is C6. Okay? So C6 also, and you try to examine, and then representative sensory zone is also there. There are a lot of confusion in this. Some of the book they write different and you are confused. The best way to remember, this central one is C7. So now you know this is central one. So outer one will be C6 area, and this will be going to C8. Okay, C8, T1, T2 higher up. All this. Okay. Now, anyone can explain me what is this inverter, supinator, or brachioradialis reflex? No?
Normal brachioradialis reflex, when we use a knee hammer and tap on the insertion of brachioradialis, we will see the contraction of the brachioradialis muscle. But in cervical myelopathy, when we examine the patient, instead of the brachioradialis contraction, we will see the finger or the wrist flexion.
Yeah. So, and apart from brachioradialis, sometimes you find flexion of little bit elbow also, sometimes it may be there. Now here what happens, suppose you have a 5-6 disc prolapse. Okay, this is another confusing thing. The level different in cervical spine and lumbar spine. So C5, C6 disc prolapse will compress which root? Hmm? 5 or 6? No. See, there is a mixed answer. C6. Between 5, 6, 6 comes up.
Cervical C5 traverses at the exit at the below the pedicle of C5. Means upper level.
L, that is L5. L5, see, most common disc prolapse is L4-5. So L4-5 is the disc prolapse. Which nerve root is the traversing nerve root? L5. L4 is the exiting, and which is mostly compressed, unless it has migrated up, which is more compressing. L5 nerve root will be compressed by L4-5 disc prolapse. L5 will exit below the L5 pedicle. This is clear. But here in cervical spine, it will be C6 will be coming out.
Yeah, this is very important what Sir is trying to say. In the lumbar, there is a traversing nerve root and exiting nerve roots. Usually that exiting nerve roots, they exit at the pedicle above and the traversing goes down. In the cervical, the root orientation and traveling is different, but the number of nerve getting compressed is, in 4-5 it is 5, 5-6 it is 6. And also we should remember there are only, how many cervical vertebrae are there, or how many cervical roots are there? Yeah, 7 vertebrae and then 8 roots.
8 roots.
So that also is a big
gives you idea. Okay. So this is important. So you have to localize your neurological level. Okay. C8, this intraossei, C8. Adduction, abduction, this is important. Finger flexors, and this is C8, outer aspect. C8, T1 is here, T2 is higher up. Okay. Then, okay. Now this again, I think this was from the myelopathy I had taken up. Pyramid sign. This is reverse pyramid sign. Okay. So extension catch is there and patient is there. This is jaw reflex. So suddenly there is a contraction. You just put a thumb there and try to tap. So good. It means the lesion is above foramen magnum. They are deciding how to decide which level it is. Scapulohumeral reflex, you tap on the spine of the scapula, that area, and patient will have abduction, sudden abduction of the shoulder. Okay. Then hyperactive hypoctorious reflex. So put in that fossa and just tap on that. So patient will have adduction and internal rotation of the arm. This I think you might be knowing. This is again commonly practiced. You flicker this and there will be flexion of the thumb and the medial fingers. Indicator of corticospinal pathway dysfunction and patient sign of upper motor neuron. This is Wartenberg sign. Ask the patient to keep it adducted. After some time it will get abducted and extended. Okay. Again, a case of myelopathy. Grip and release test, he will not be able to perform the 10-second time spent cycle. Normally, person is able to do 20 times, but he will not be able to do. Okay. Inverted radial reflex. This actually I had asked him, tapping the distal brachioradial tendon. Positive finding is what? It is again in myelopathy or cervical cord compression, this may be there. And this muscle testing, okay. And this is important when you are suspecting in term of myelopathy, okay. This is important. And also, patient have muscular problem, you see, myopathy. Also in upper motor neuron pathology, if there is a, absence of unilateral abdominal reflex is important, okay. If there is a absence, then you think there is some intraspinal pathology and there is a compression somewhere. So one has to be careful in analyzing these findings. Okay, So this is a function of erector spinae muscles which you try to test. Okay. Again, what is this? Anybody? So one area is actually paralyzed, the other area will contract that side. Okay, also known as Beaver's sign. And this is the sensory dermatome in the truncal area. So nipple area is usually T4. Again, it will be helpful for you to diagnose what level my neurology is, and that's why you will try to analyze the pathology affected. Here, sometime there, but whatever red mark I have given, they are the major contributor to that. Okay, extensor S1, L5 is the abductor, and gluteus medius. So never always just test EHL and all. This is testing is also important. Okay, knee flexors L5, extensor 2, 3, 4. Then ankle, dorsiflexor 4, plantar flexor S1, inversion 4, 5, and eversion S1. So these red things are actually important. Even like this you can remember. Okay, L1, L2 is iliopsoas, 3 is quadriceps, 4 is just start going down and remember this. Very easy. L1, L2, iliopsoas, 3 is quadriceps, 4 is tibialis anterior, EHL is 5, S1, plantar flexor and everters of the ankle. Very simple. Okay, and don't get confused with the overlap roots. It's not. Okay, again you test all when you are examining the lower limb. Again reflexes, sensory dermatome, what reflexes, what is the value, like ankle S1 it is. Okay, then testing for S2, 3, 4, bladder wall function, intrinsic muscle feet function, and sphincter. When you have not examined the patient's sphincter contraction, say that you have not examined it. Okay, so there is no problem. You see all these jerks, brisk jerk, there may be clonus, superficial also abdominal, cremastic, anal reflex. Okay, and pathological reflexes. You test for any Babinski, all these upper motor neuron, open hem test, and then you see for the clonus. Okay, sensory, all these sensory dermatome behind and front and side. You should know. Okay, and this is important slide. Localization of leads. Again, here maybe little bit variation. Maybe there are books to book, but this is confirmed one. C1 to C4 same level. Whatever there, it is same. It is not going to change. 5 to D1 plus 1. D2 to D5 plus 2, D6 to D9 plus 3, because chord ends at L1. Okay, so that's why this is important to know. D10, 12 to L1 to L5, L1, S1, S4, and then there's a chorda equina at the beginning of this L2. Okay, and this is very important. You must examine the vascular area. You must put your hand on the dorsalis PD, try to palpate, okay, posterior tibial, and sometime there may be issues. The problem patient has the vascular area, and you should know how to differentiate between neurogenic claudication and vascular claudication. Again, nearby area is another is SI joint. So this SI joint problem and hip problem, it might create confusion for you in the lumbar spine. Okay, so you should know properly examination of this part, compression. So basically all these tests you are trying to do what? You are trying to create some movement in the inflamed joint, and patient will have pain. Okay, so see, in one go you can examine all these. You have first put your hand to the feet of the patient. You are asking his permission to examine. This is in our book. So keep your hand. So you have palpated the dorsalis pedis, and this is the Indian customary to respect your elderly. Okay, you have palpated the dorsalis pedis, you have palpated the posterior tibial. Okay, now you just try to lift it up. You will know SLR. Bend the knee. You have, and your palm is there on the this knee, left knee. You have put your left hand. So you know what is the status of knee joint. Then you flex the hip, rotate the hip. You have done the rotation. Hip, you know the maximum, whether it is normal or it is affected. And then same time you try to hyperflex and do the pump handle test. SI joint also you have tested. Then again try to stretch this, put the feet on the examination table, ask him to lift EHL, test EHL. So quickly you can finish this part in your heavy OPD. And this can be done very well. There is no issue about that. Okay? So compression test, distraction test, pump handle test, then Ganseland test, Gilly test is done in the prone position. You just try to hyper extend it. Then active SLR. Again, the same thing I asked. Active SLR is for SI joint. Okay? Patrick Faber. So what you are making like a figure of 4 and try to extend the hip, patient will have pain. These are non-organic signs of it. This is basically where patient is actually, he is not trying to tell you the truth, he wants just certificate. Okay? Malingering. So this is for malingering. Okay? So even you touch, patient will have severe pain. And just engage in some talking test here also. Again put there is no pain. So you have to basically confuse the patient and do all this, simulation sign. You have done the same movement without the guard, okay, but was not having any pain. But first time he winced with the pain, all these things, okay. Then distraction sign, you distract. So now here, this is actually SLR in sitting position, okay. Then regional sensory and motor distortion patient might be overreacting to it, okay. Hoover's test. Can you explain anyone what is this Hoover's test? So it is a natural tendency. You just keep heel of the patient on your palm, both the side, okay, and ask the patient to lift the affected side which he is complaining of pain. So normal tendency is that when you raise this, you try to push the opposite hip downward. This is a normal tendency. Okay? So if there is no pressure, then what will happen? He is not trying to lift only. He is showing that I am not able to do it. Okay? Because that pressure will not come there. Okay? This is Hoover's test. Again, to test for the malingering, really malingering. Now this I just mentioned. I will not take your much time. Just to mention, you should be aware about what is the difference between neurogenic claudication and vascular claudication, okay? What is the presentation of intramedullary, mass or extramedullary when the patient is complaining of these things, how to differentiate. Then this is a classical classification for knowing the activity of the patient in the case of myelopathy, whether it is a mild, moderate and severe. Remember, all these cases, 3 is the borderline. We do this bone densitometry, 3. After Singh's index, osteoporosis, 3. And after that, up and down, one normal, another side is abnormal. Similarly, here also, here moderate means able to do this, severe he is confined to bed. Okay, this is the neuric grading. Grading 3, great abnormality, prevents problem, but still he is able to walk. Okay, so higher up it is less, lower down it is more. Okay, now this also important, grading. Grading usually normal, we say it is 2 plus 2. Plus 2 is normal. Okay, this is grading for spasticity. All these are given, so you must do. Sometime you are asked about, if your Viva is going really well and you have a case of myelopathy, they will ask you, what will be the JOA score? Because it is because of the clinical finding. You say, and nowadays we have, initially we used to have 17, now it has become 18 with this modified JOA score, and use of no sensory assessment for trunk and lower extremity. Chalo, thank you very much.
Thank you, sir. Thank you very much. Any postgraduates who are on any doubt or in a clinical examination, you can just clarify. I think it's usually we don't keep spine cases, but nowadays it's becoming a habit to keep small case. Why not, sir? You're keeping small cases, sir? Spine. Long case. Mm-hmm. Oh, spine you are getting a long case, mostly tuberculosis or disc prolapse. Yeah. Neurological deficit, neurological examination. So any doubts from the postgraduates?
See, I usually tell my PG, more study, more confusion. Less study, less confusion. No study, no confusion. Everything is understood. Okay. So anyway, it is not an end of the day for your teaching. So you should try to learn the way it has to be done. That is most important. History taking, clinical examination. Don't write X-ray, MRI. Why you want to see? First question yourself. I want to see what? What clinical finding tells me that I should do this? And what will be the finding? And practical approach is very important. See, nowadays in an exam, what will you do this? So even if you have, actually practically you are asked management, okay? So what do you practice in your routine in OPD? You just ask that much, it is sufficient, okay? Now, suppose you suspect a case of some severe, injury for that matter. So you want to see the X-ray. So say X-ray. Don't say that I will do CBC, ESR. That practice is now vanishing gradually. It should not be there. You are an orthopedic and a spine surgeon, so you have to tell in that way what you want to see. Suppose, and hemoglobin will be visible even with your general examination, whether patient is severely pale or not pale. So it should be, make it a practice. And if you are asking some investigation, you ask yourself, what are the possibility that I will find in the X-ray? Because exam, the same thing is done. If you ask for MRI, so then the examiner will ask you, what are the things you are expecting in MRI? Without seeing the MRI, what are the things you are expecting? And then you see the MRI and tell the finding. Okay?
Any final year exam going postgraduates here? Exam going.
Actually, Dr. Naresh, now across the India, nowadays in MS orthopedics, long case is hip case or spine case. Most of the time, I think. No. I think here also they have started.
We also slowly starting.
See, just not related to this. There was a problem in our SSI that we should fight that, orthopedic surgeons should be able to do spine surgery. And there was problem. Even in getting the money also there is to be problem. And it was addressed, because one of the person, he lost the case. Okay, why did not you keep the neurosurgeon? So,
that's from Vijayawada only.
Achha. So, thing is that, and the lawyer from the, our society, which we had discussed in great length, he told you should be able to operate, whether it is taught or in your orthopedic book is there. Orthopedic book, there is a big chapter on spine. In fact, we get long case in spine. So you have full right to operate on spine. If you are doing intradural thing, intramedullary, which are not being practically taught to us in practical, that case it is okay. Otherwise, spinal column we are doing, you are entitled to operate this patient because you are taught during your MS, you are evaluated for that, so you have every right to do that.
Thank you, sir. Closing remarks.
So thank you very much. I enjoyed a lot. Thank you.
Thank you, sir. Thank you very much. So we had a great day. I think after a very long time, I'm listening how to examine the spine in a proper way, and all those things which we used to read, which are very important in the exam, but we usually tend to neglect in our day-to-day practice. Try to directly look into the MRIs and all. I request our APMC observer and Secretary of UOS, Dr. Vasu Garu, to give the closing remarks.
Yeah, initially hall is very active, but by the end of the day, I think. So anyway, we had a good session by Professor Dr. Rajshekaran and Dr. Srivastava sir. So thank you, sir, for being both of you here and having a nice day with SSAP.
And I thank all the consultants who are from Guntur, Ongole and all the postgraduates from different colleges. I think you should have got some more interaction with Srivastav sir, but as sir said, nowadays they're because going through the Google and all, they have all the on chat GPT, so they can have all the answers so anyway, thank you for being here, and I thank Dr. Naresh for and his team for making a successful event today, especially from Guntur, all the spine surgeons, and even from Vijayawada, many of our youngsters were there. So congratulations for being part of this program and having a good interaction. And finally, I thank all the organizers, especially Sun Naresh Garu, Sun Pharma, Ravi Kiran, and he's a senior manager, I don't know his name, and all the audiovisual team. So thank you. And from Vizag also, Leela has come and many more, which I didn't name them, but thank you, sir. And any other remarks? తెనాల నుంచి సాంబశివరావు గారు, హనుమంతరావు గారు, అదే ఫస్ట్ బెంచ్లో కూర్చున్నారండి, ఇందాక అదే చెప్తున్నాను. నైస్ టు సీ యూ ఆల్ వన్స్ అగైన్. అండ్ మా ప్రెసిడెంట్ గారు అలాగూ ఉన్నారు లాస్ట్ దాకా. థ్యాంక్ యూ సార్. ఓకే, థ్యాంక్ యూ. I have coffee and go, I think.
Thank you all. You will all get that APMC credit hours to your email ID, and they will be directly credited to the your account, your APMC account. Sir? Yeah. Yeah. Okay.
QR code will be displayed. You can log in from your mobile and fill the details, so that directly it will be registered, and you can have your credit hours into your account, whoever is registered in APMC. And anyone who hasn't made online in APMC, try to make it, so that now the things have changed. You should get enrolled in APMC online. Okay, thank you.
Thank you, sir. That last event of the day, so our beloved President of SSAP, Dr. Vayanar Garu, completed his 2 years term successfully, and Dr. Narayan Rao Garu is going to take over as President of Spine Society of Andhra Pradesh. Incidentally, Dr. Narayan Rao Garu is getting retired. This is his last working day from government service, so we are making him as a first working day in our SSAP for that to happen. So, sir, few expressions. So you can shall shall something. Me ka mere eltanarga meek iste. Yeah, thank you, sir. No, yes, okay. Also, sir. Narayan Rao sir ki. MJ Edgar sir. Sir, please join us, sir. So it's your first working day in Spine Society of Andhra Pradesh. The last working day of government service.
All the best. So thank you very much. It's a 2 years period, 3 years period. No?
3 years, yes, I think.
You made it for 3 years for me, especially. Thank you, Naresh. It is always very pleasant, even if it is painful sometimes. But it is with Naresh, it is always pleasant. We can bear anything with him. He can bring out so much good for all the rest of the association or something like that. And Narayan Rao Garu, I'm very happy that I'm handing over to Dr. Narayan Rao Garu. He's such a nice gentleman. And the day of his retirement, this is something very happy occasion.
Thank you. Thank you, sir. Thank you, sir. Thank you very much. And once again, Thank you for electing me as a president of this Spine Society of Andhra Pradesh. And Naresh is always with us. With Naresh, we can do anything. Thank you very much. Wishing you all the best.
That is true.
May I request Srivatsa sir also to be there in the president of ASSI in the Spine Society of the center. You can just consider. So you guys want to join for the group photo? You can just come and join for the group photo after this one. One picture I put. Yeah, everyone can join for a group picture. Backside. Please. Fine. Okay. Yeah, yeah. So a lot of postcards from Amalapuram. Sir, 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 Sun and spine goes together very well for future also. Thank you.